But just make sure it doesn't get down. Take it down. We take it out, make sure.
That is the first time being here since we did these. Yeah. Remember those old metal ones? Oh, yeah. Not all, it's just like Carolyn was very
Alrighty. We are ready to get going. It's a great day. Everybody come in a little bit closer if you would, so make it feel warm and fuzzy for Dr. Sutherland. A lot of alumni here today. It's good. All right. Hey, Stacy, can you see if there's anybody out there to bring in good? Dr. Rao, Dr. Pennywell back there? Is he out there eating? Okay. All right, I'll get y'all to take your seats, and we'll get started. Usually we finish a little early, and so I know if you've seen the dossier for today, it's a grand time for us. It's the most favorite time of the year for me. I know it is for a lot of you, especially for the 5 chief residents that are about to head in their respective routes and patterns. So we're so happy to start this day, which is our 51st Abramson Visiting Professor presentation, the presentations from the residents. So we're so happy to have you here. Very happy to have Dr. Zabari, Dr. Altman, and those guys from Willis-Knighton who've been active in the educational process here at LSU from the get-go, and I hope it continues, and I think it will. So we have a great day today. I'm going to introduce Dr. Sutherland formally after the presentations. And Mike, what we do today, we have 3 presentations from research, and these are the top 20% of the 15 presentations that we presented throughout the year. And some of these are novel findings, some of these are retrospective studies. And we'd ask you to look at these, grade these in your mind, or write things down, whatever you think. We'll ask you to kind of pick a winner, not only for the research presentations, but also for 3 clinical case presentations, which I think you'll find very interesting. So without further ado, We'll start with the resident research presentations, and Dr. Emily Adams is going to present implementation of antibiotic stewardship program improves compliance and length of stay after trauma. Dr. Adams.
Hi, everybody. My name is Emily Adams. I'm one of the fourth-year residents here at Ochsner LSU Health in Shreveport. Today I'll be speaking with you all about a project I did with my mentor, Dr. Samra, looking at outcomes following implementation of an antibiotic stewardship program in the setting of open orthopedic trauma. Thank you for allowing me to present. I have nothing to disclose. So an open traumatic fracture is defined as a fracture in which the overlying skin and subcutaneous tissues are violated, resulting in exposure of the bony fragments to the external environment. This places these bony fractures at a very high risk of infection, given the contamination that likely occurs. This is usually due to Staphylococcus and is most commonly located at the tibia. The tibia actually accounts for 10% of these open traumatic fracture infections when compared to 5% when all other fracture sites are combined. The current treatment of open fractures and trauma includes a multimodal approach in which there is initial fixation, early irrigation and debridement, tetanus vaccination, and most importantly for this project that I did, systemic antibiotic therapy given within a timely fashion. The role of antibiotic therapy was first described in 1974 in a prospective study that was done that had two arms of the study, and it looked at patients who received antibiotics and those who did not. In the patients who received antibiotics, there was a statistically significant decrease in the rate of infection. This was taken a step further by Castillo and Anderson, who later looked at antibiotic sensitivity profiles of the bacteria that these patients developed when they did have a wound infection here. And they used this to further classify these open fractures, which is referred to as the Castillo classification of open orthopedic fractures, which is commonly used by most institutions today. The timing of antibiotic therapy was first described a little bit later by the same group, and they found that there was a statistically significant decrease in the rate of infection whenever antibiotics were given within 3 hours initially. This was taken a step further, and they looked at the difference whenever they were given within 1 hour versus 90 minutes, and they found a decrease in the rate of infection from 27% to 6.8%. And this is why most institutions use the 1 hour rule as a common guideline in determining when antibiotics should be given in patients who present with open orthopedic fractures. So we first decided to develop this study in 2019 when our institution realized that there was a significant increase in the time to antibiotic administration observed for the year of 2018 when looking back at that year's data. They also noted that at that time, only 12.5% of the patients who presented with open traumatic fractures actually received it within 1 hour. So a collaborative effort was then pursued by the trauma team with the help of the ED team, the orthopedic team, as well as the nurses and pharmacists that are involved with trauma to develop a antibiotic stewardship program, which involved a guideline of which antibiotics should be given and a workflow process that showed which antibiotics should be given, who should order the antibiotics, and the time at which they should be ordered. So it was our objective for this study to determine whether or not there was a statistically significant change in the time to antibiotic administration following this antibiotic stewardship program implementation. So this was a retrospective review. We looked at data pre-ASP or antibiotic stewardship program implementation and post-antibiotic stewardship program implementation. We collected data on all adults who presented with open traumatic fractures between January of 2018 to December of 2021. And we looked primarily at the time to antibiotic administration and then looked at the proportion of patients that received these antibiotics within 1 hour, which is the guideline we use here at LSU Health in Shreveport. We also used hospital length of stay as a secondary outcome in our study. We hypothesized that the implementation of the ASP would help with compliance of antibiotic administration in open orthopedic fractures, meaning that more people would know the guidelines and the workflow process to actually administer these antibiotics in a timely fashion. The results of our study are listed here. And just remember that our ASP was implemented in 2019. So as you can see, there was a significant improvement in compliance of antibiotic administration, meaning antibiotics given within 1 hour from the year of 2018, which was only 12.5% at that time, and it increased to 81.7% in the last year of our study. There was also a significant decrease in the median time to antibiotic administration, which was initially 211 minutes when compared to 20 minutes at the last year of our study. Incidentally, we also found a significant decrease in the median hospital length of stay from 8.7 days to 5.52. It's not known whether or not this is actually due to this antibiotic stewardship program implementation or not, but it was something we found, and it was statistically significant. And this was despite a no significant difference in the injury severity score in these patients. So in conclusion, our results show that implementation of an antibiotic stewardship program at a level 1 trauma center can be effective in improvement of compliance. And also, like I said, we incidentally found this decrease in hospital length of stay, so it's not known whether or not that was what contributed to this decreased hospital length of stay, but it's something that we're looking at right now, and we're planning to collect further data on whether or not there was a decreased risk of, or decreased rate of infection in these patients, which could contribute to this decreased hospital length of stay. These are my references. Then I'd like to thank our medical students, Kaylee Leach, Zach Connolly, then Mike Nolan, thank you, I see you over there, and then Miss Wendy Chris for their help as well in this project. Does anyone have any questions?
Very nice presentation. Did you correlate, because you had classification of the degree of the severity of the fracture and the trauma, did you correlate the decrease in the length of stay and antibiotic stewardship to the categories of?
So the Costello classification? No, sir.
Valid or not?
We did not. We did use the injury severity score, but that actually is a really good idea to do, to see if there's the same proportion of severity in terms of the open fractures, because a type 3C actually requires a higher level of antibiotic than a type 1. So that would be something definitely we should look at. Yes, sir.
Very, very nice presentation. I was going to ask the same question about the Castillo degree, but in addition to that, you're seeing a lot of open fractures, somewhere in the neighborhood of 500 a year, which is a little bit less than 2 a day. So, I mean, that's a robust number in order to work with and to study. And my question is, have you identified what barriers are precluding you from reaching 100%? You've still got some, 18, 19% there to work with to close the gap between what an ideal state would be. And has this review of your cases provided any insight into what could be done in your performance improvement to achieve that?
I know initially there was a lot of confusion in the trauma bay of, which antibiotic should be given, who's responsible, is it the orthopedic team, is it the trauma team, that should be ordering this antibiotic? Because a lot of times it's like someone else is probably ordering it, I think, kind of scenario, which is like, why the compliance was so low initially. But I'm not sure why we haven't reached 100% yet, to be honest. We're providing continued education to the nurses, making sure that the correct antibiotics are in stock within our trauma bays. And the pharmacists are on board as well. But I'm not sure. Maybe Dr. Samra, I don't know if you know why it's not 100% yet. But I'm not entirely sure, to be honest.
One time instance that they were not stocking the antibiotics in the trauma bay. The decision was made at the campus also. So we requested them back that it should be able to override it and just give the antibiotics. That was one small operation issue.
It could also be maybe just like when a patient comes in with a very severe polytrauma, rush roll to the OR, maybe we can work with our anesthesia team even to make sure that these antibiotics are given in the OR in that case.
An amazing story here of an improvement in the time to administration, and you've got an amazing improvement in the number of patients that are receiving it. But, you know, we were talking earlier that you do a project and then you find other projects inside that project. And I think this is really, you know, revealing, because you seem to have plateaued from 2020 to 2021. And I don't know if that carries forward into the current years or not.
So that we track compliance, and every month in the fifth PSC meeting, the constant shaming maybe just was presented.
It's a very effective tool.
Yeah, and then also we can go to the next level with the ongoing trauma review in the lesions. We can start documenting it, that how you did. So the onus will be on the traumatologist who's on call.
Mike, do you have any comments? Mike is really commenting on a lot of this data, ultimately involved with our stewardship. Any comments from you? No. Okay.
Dr. Zubair?
Congratulations, nicely done.
Thank
As you know, we all struggle to get these patients out of hospital.
Mm-hmm.
You know, have you, the hospital made some progress in regard to finding rehabilitation for patients to go or social situation? Because we get stuck with these patients trying to get them out. So it really negatively impact linked to hospital stay, if you have any comment about that.
Yes, sir. I know that when COVID was going on, that was a huge issue because I was an intern at that time and I was the one, you know, kind of handling the social issues. But I'm not sure. I couldn't really comment with confidence, you know, with.
Unfortunately, when you have a reduction in force, the first thing that goes is quality, looking at value, and some of the social working issues. We've struggled with that, guys. You know, one thing I didn't realize is the number of beds for acute and chronic rehab are above the national average in Shreveport. It seems like we should be able to fill it. Unfortunately, our payer mix is predominantly Medicaid.
Health statistics, there's been a paradigm shift in that younger patients are now being diagnosed with more advanced pathologic stages. And we see that in day-to-day practice when we meet patients in clinic that are diagnosed at earlier ages and with more advanced disease. Particularly, there's been an increase in the incidence of left-sided cancers and rectal cancers. According to large retrospective reviews from the National Cancer Database and the SEER database, approximately 20% of patients nowadays being diagnosed present with metastatic disease. And the role of metastasectomy for the treatment of stage 4 colon adenocarcinoma has been evolving. There's a multitude of factors that play into the role of how these patients end up doing from the treatment outcome standpoint. It starts with differential tumor biology in the patient itself, and also patient demographics play a role, as well as clinical pathologic variables. There's also a lot to be said about the external factors such as hospital system, access to care, and also treatment-related factors that play a large role. The aims of our project were to identify socioeconomic and clinical pathologic disparities associated with metastasectomy for oligometastatic colon cancer through a large population-based analysis, and we elected to use SEER for analysis. So we also examined regionalization and determined where are these patients in SEER being pooled from. Are they coming from more urban metropolitan areas or versus rural areas? And lastly, we did a survival analysis between the hepatic versus pulmonary metastasectomy groups to see if there was any pertinent differences. In regards to our methods, we obtained IRB approval. We queried the SEER database for all adult patients who were diagnosed with stage 4 colon adenocarcinoma histology, particularly who underwent either pulmonary or hepatic metastasectomy during the years of 2010 to 2019. We looked at the clinical pathologic and socioeconomic factors, and we analyzed the outcomes from patients who received metastasectomy. We looked at overall survival using a Kaplan-Meier analysis and compared each using log rank tests. This is a flow diagram here about how we got to our final study population. We initially queried the database for colon adenocarcinoma histology from that time frame listed there and queried roughly 156,000 patients. We excluded patients who were under the age of 18, any patients who did not have unknown disease stage listed, any unknown demographic or socioeconomic data, as well as any unknown treatment modality. And because these large databases have some data capture variability between institutions, a lot of patients have to be excluded due to inadequate data provided. And we looked at only stage 4 disease. So that left us with about 32,000 patients who had stage 4 colon cancer. From that, a majority of whom received likely definitive chemotherapy, so did not receive surgery, 28,000, and patients who did receive surgery was roughly 3,300. We stratified that into two cohorts, a pulmonary metastasectomy group of roughly 376 patients and hepatic, which comprised of 2,500 patients. And that's how we got to our final study population. In regards to regionalization, from the SEER database, it was evident that majority of the patients came from metropolitan urban counties, which accounted for 86% of the population from SEER. There's an underrepresentation of patients coming from rural counties, and that's an area for further investigation and improvement. And as we know, the academic health centers as well as integrated cancer networks are primarily located in metropolitan urban areas. In regards to the median family income, it was noted here in the Kaplan-Meier analysis that higher median family income of greater than $75,000 per household was associated with improved overall survival at 38 months compared to lower median family income of less than $35,000 with a survival of 19 months. And this was statistically significant using log rank tests. In regards to racial disparities, we see that comparatively non-Hispanic white patients underwent surgical intervention at a higher rate compared to minority races. Non-Hispanic white had roughly 62% of comprised 62% of the population, whereas minority races altogether comprise about 37%, and this was statistically significant. And while there is some basis in that for racial disparities, there's some inherent tumor biology that is different, socioeconomics play a strong role in determining a patient's access to care and eventual overall outcomes as well. In regards to age, we did not see any significant gender disparities in patients undergoing surgery. This was not significant. And in terms of age at diagnosis, majority of the patients who underwent surgery were diagnosed between the age of 56 and 65 years of age. I think this diagram is interesting because nowadays there's a lot of talk about the early onset colon cancer, colorectal cancers being diagnosed. So the column here of less than age 45. And so this is an area where I think over the years, there's going to be a trend to this column increasing in the frequency of patients being diagnosed at an earlier age and with more advanced disease. So that's an area for further research and investigation. In regards to CEA, as we know, CEA is a marker of a tumor recurrence. In our study, CEA was a strong indicator of decreased overall survival if it was positive. At about 32 months overall survival, and a negative CEA amounted to 44 months, and that was statistically significant as well. In terms of a primary site of disease, we looked at where the primary tumor location was and noted that sigmoid colon cancer had improved overall survival compared to other parts of the colon, particularly right-sided cancers. There's numerous literature about why this could potentially be the case, one of which includes that typically right-sided cancers have higher expression of biomarkers such as MSI, KRAS, that make it a more biologically aggressive tumor compared to left-sided cancers and hence have a worse prognosis. This is a survival analysis for hepatic versus pulmonary metastasectomy, and here we see that the hepatic group had improved overall survival at 34 months compared to the pulmonary metastasectomy group, which had survival of 22 months, and this was both statistically significant. In conclusion, there's numerous socioeconomic and demographic disparities that exist regarding treatment received and the outcomes for oligometastatic colon cancer. In our study, we determined that minority races, patients coming from lower income families, as well as patients residing at rural counties are less likely to undergo surgical intervention and have worse overall survival. Identifying these specific disparities can lead to more targeted interventions for patients who need to have access to multidisciplinary care at integrated healthcare networks with tumor boards present and ultimately improve patient outcomes. That being said, there are limitations to doing these large retrospective studies as there's less granularity present in answering the specific question that you are after, and there is some variability in data capture because most of the data for these studies is coming from nurse navigators entering these information in from various NCI cancer centers. One thing that our group looks to expand on for this study is to do a binary logistic regression model using univariate and multivariate analysis and answer the question, in patients who did have oligometastatic disease, who did not have surgery versus did have surgery, what were the factors that led to the treatment modality that they received? And that's something that we're working on now. These are my references. I'll take any questions.
Very good effort on you and your team to analyze these studies. One thing which is very important, that you have from 150,000 came to study 2,500. So in itself, it says that any conclusion cannot be valid, because there are so many biases are included there. You have ignored a lot of things, not by the study design. So the best, as we know, would be to run a randomized control trial that have all the things measured, maybe 2,000 cases altogether, and everything will be concluded. Here, you have a lot of work to come to this conclusion that I cannot really get anything out of it.
Absolutely, and I think that's a huge limitation of these kind of studies, because you start, like you said, with a huge population, and it gives you the power to do like powerful statistics, but at the same time, you're having to decrease the actual sample size because of the data capture limitations, unfortunately. But
I think the study does have merit because it pulls out some socioeconomic things that occurs not only in oligometastasis and colon cancer, but also lung cancer, melanoma, things like that. Now, the question is why? Is this an educational issue? Is this a mistrust from the minorities and the people that have been affected by this not to seek medical care? Or is this an access to care issue? Or where do you think this lies? And that's one thing about these studies that show that there's a disparity in treatment of people of color, marginalized populations, versus people with commercial insurance, et cetera. But why?
So I think to answer your question, I think access to care is a big thing in terms of literature from these larger studies and even more site-specific studies. I think access to care and distance to the hospital has also been studied in terms of patients who live far away from an integrated healthcare network. You know, do they have worse outcomes compared to patients who live closer and have transportation nearby? So I think that's probably a big area for research and further investigation.
Also, the screening. People are not screened sometimes from colon cancer, or these patients, if they have scopes already on, they have scopes according to the American College guidelines, American the oncologic guidelines. So
Congratulations, and nice study in large volume cases. I think always important. Periodically we see patients with both liver and lung mets. Were you able to find any of those patients, and if you did, how many of them?
So we did look at, so we had in the population, we had the primary site resected and then the pulmonary mastectomy, and then we looked at primary site and hepatic, but we did not look at a combination. But that's something that we should look at. You're right.
The reason I don't think there are too many lung lesions alone. Usually with the liver later on to the lung, but sometimes you see both at the same time. And decision which one to go is really dealer's choice. It doesn't make any difference. Second thing, did these people receive chemotherapy or not? As you know, liver surgery really have changed.
Yeah.
Before we attack primary site.
Yeah.
Nowadays what we call reverse approach of mortality. So of course rectal lesion, all get radiation chemo before you do anything else. So it would be nice to look at those numbers, and I'm certain maybe all the information is available.
Yeah.
But will make an impact. And lastly, with patients, we're looking at rural versus metropolitan. Are you looking at people who live there or getting benefited?
So in the zip code that they're coming from, and like so that's the zip code they're attributed to. So there is, I think, a skew in the data because the rural population, is really not being represented well in SEER. I think there's probably patients who are receiving some form of care, I think that's an area for further investigation. Sure.
Actually probably know this one. Does SEER provide you with the type of insurance the patient has?
So it has, insurance status. I think NCDB does a better job of stratifying it better, but it does.
So I think what would make it more powerful, because I think this is fantastic, and I'm glad you're presenting it at ACS, because I think it's really important. Looking at the type of insurance they have, because not only are these things expensive for the patients to get to the hospital, it's expensive for the hospital to have this stuff. To have, HIPEX is the easiest example, obviously, but like to have ablation, to have IRE, to have these things, and a hospital that doesn't have insurance isn't going to pay for those things either.
Yeah, definitely. I'll try to look into it. Yeah.
Have you done anything to look at the findings that you identified here in relationship to the local patient population? This is a great review and look back at a very large population, but does it represent what you see here in Shreveport? And what types of things can you take from this that would be applicable here in your local practice?
Great question. I think you're absolutely right. I think there's a lot of things in this study that we see just with our day-to-day interaction with patients. And I think for sure from the multidisciplinary tumor board discussions we've had with Dr. Larimore and seeing some of the patients in his clinic and everything, I think they could definitely benefit from having earlier access to care and being referred earlier. I think that's one thing I've seen. There's been delays in referrals from patients who are in various smaller towns in Louisiana and other parts of the country as well. I think that would be a great thing to look at. But no, right now we have not looked into it. But anecdotally, I do think that this would be applicable.
Dr. Sutherland, a lot of our advanced cancer cases come from Region 8, just like trauma. Right. We have such a propensity of trauma and access to care over there, whether it's trauma, early cancer diagnosis, and screening. It's just not there. So that's why we really try to concentrate, especially talking to Asha, how can we advance cancer care over there at an earlier rate? And Dr. Thayer has really been exceptionally helpful.
You guys are leaders in the education of physicians in this region. So this is a great study to bring around the idea of, is this a barrier to access? Is it a barrier to programs that provide the care in the communities? Or is this a transportation issue? And then, what can be done to emphasize this in the primary care individuals that serve the community that are educated here? And how do you start to pivot and shift the tide a little bit to identify ways to improve that access or improve that ability for the patients to get the screening? And LSU Health Shreveport has always been a leader in this part of the state, and this is the kind of study that brings to mind, what can we as leaders do to impact outcomes in our patient population that we're responsible for.
If you look at the propensity and the density of primary care physicians in Region 8 is half what it is in Shreveport. So to try to get people to go to the Monroe area, to Region 8, to try to deliver preemptive care, screening, et cetera, it's just been very difficult.
I just want to make a brief comment. I just want to congratulate Dr. Paul on the large amount of work he did on this study and a parallel study we also did to look at hepatocellular carcinoma. And we chose in particular that because of the wide variety of treatments that patients can get with hepatocellular carcinoma. They can get resection, they can get catheter-based local regional treatments, and they can get a transplant. And our hypothesis was that there would be a very large range of what people would get. And surprisingly, in that study, the most common treatment that patients got was no treatment of any kind. And so I think Dr. White's comments really hit on this paper. These studies, and I have to respectfully disagree with my esteemed colleague, Dr. Mary, that the conclusions are not valid at all. The power, while there are many biases in studies of administrative databases, the power is the very large sample size that you start with, and that it samples, SEER is set up to sample a large different regions of the country. But having said that, I think that the reason to do these studies, they're descriptive studies, unless you intend to use the information and the trends that you find to identify actionable things where you can reduce those gaps.
That's the purpose of the study. Otherwise, it's just a descriptive study. And I think the most important things, the most eye-opening things to me of this study is that if your income is lower, that your survival is lower. Okay, there's a variety of things that could account for that. It could be that you don't have preventative care and you prevent later. It could be that you have ethnic biases and seeking medical care and trusting. But probably the most important factor is access to care. And so I think that everyone doesn't get the same opportunities. Everyone doesn't, it's not a level playing field. And so I think these disparity studies are very important because when we identify these trends of the people who are doing poor, it's, we need to figure out what's actionable to reduce those gaps. Thank you so much.
Great. Just a comment about research. These are resident research projects. We say they're faculty, but every one of us know who does the hard work. We may come up with the idea, and I look back and ask some alumni about this and how long has this been going on. Dr. Sabari can tell you the piles of charts that he had with some of the great studies they did in transplantation and renal failure got published in the Annals of Surgery. But he did the work. It wasn't John McDonald, it wasn't Ed Deitch. Kevin Satie can tell you, translocation, who did that research? He did. So I want to put credit where credit's due, that this research projects, we may have an idea because we have a pretty good broad scope of the literature, but you guys do them, they do the work, and I think that's why we have to do due diligence with that. Wendy, Zach Conley, people like that we've been using as adjuncts have helped us dramatically with biostatistics, and that's why the papers, I think, continue to get better and improve. But Donnie likewise has done some studies early on with Dr. McDonald. And we had 2 PhDs when Dr. McDonald was here? We had, that's right, we had 2 PhDs, and we're fighting to get 1 PhD, and we've had one where we've paid on an ad hoc basis. But we continue to strive to help with surgical education and research here, and it is a battle, especially when you have a partner that's basically a clinical partner. And I think Ghazi fights the same battle, with Willis Knight trying to get those monies for adequate research projects. So, residents, thank you. Interns, it's the literature that produce here is all on your backs, and we appreciate it very much. This next study, likewise, is a study that I thought of, and we actually had a guest speaker here about 4 years ago who spoke about drug-induced aortic dissection, who is really one of the leaders in the United States and works with some great aortic dissection surgeons in Houston. And he came up with the idea that the early occurrence of tendon rupture with fluoroquinolones could equate into problems with connective tissue. And when I brought this up to Connor and Garrett, the 2 co-investigators in this study that we're about to present, they took it and ran with it. He and these 2 guys with Zach Conley. So I'm going to tell you, thank you. They found some novel findings in this paper which you're about to present. But once again, they took it, evaluated the data, and found some things that we didn't expect. So without further ado, we have 2 presenters here for the next paper, Dr. Garrett Lambert, Dr. Connor Eckholt, aortic aneurysms, molecular hallmarks of fluoroquinolones on the vascular microenvironment.
Morning. Dr. Garrett Lambert. I'm one of the third-year residents. I'll be presenting this in conjunction with Dr. Eckholt, who was the co-investigator for this, and I want to thank our mentor, Dr. White, Zach Connolly, and Wendy Chris, who were also large contributors to this study. So this study was titled Aortic Aneurysms, Molecular Hallmarks of Fluoroquinolones on the Vascular Microenvironment. So some introduction. Aortic aneurysms are a relatively common and known potentially fatal disease with several different etiologies. The prevalence is anywhere from 1.5% to 7% for abdominal aneurysms and 0.1 to 0.2% for thoracic aneurysms in the American population. Aortic aneurysm dissection are responsible for about 10,000 deaths per year and unfortunately results in high mortality. 20% of patients dying before they reach the hospital. Risk factors for development of aortic aneurysms include male sex, age greater than 65 years, smoking, and other vascular pathologies such as Marfan's, Ehlers-Danlos, and the other connective tissue disorders. The locations include ascending and descending thoracic aorta, abdominal aorta, or combinations, or thoracoabdominal. And the different locations are also all thought to be due to different cellular mechanisms. So as Dr. White alluded to, several studies have linked the development of aortic aneurysm and subsequent dissection with the use of fluoroquinolone antibiotics. However, to this point, the exact mechanism of this has not yet been described. So briefly on the mechanism of action of fluoroquinolones, it works on two different cellular processes, the DNA gyrase as well as the topoisomerase 4. It's a bactericidal effect, and it halts DNA replication in the cell. They have a relatively quick onset of action, and they reach peak serum levels in between 1 and 3 hours. Additional off-target effects that are known, they increase reactive oxygen species within the cell and lead to cellular damage via free radicals, which is what is thought to lead to a lot of the off-target effects. So the first fluoroquinolones actually became commercially available in 1986, and by 1991, there were already several case reports that had been published citing tendinopathies and rupture, specifically in the Achilles tendon, in patients who have been treated with fluoroquinolones. Follow-up studies in animal models showed increased inflammation and reactive oxygen species in tissues of rabbit and mouse tendons that had been treated with fluoroquinolones. And this was extrapolated to concerns that this inflammation could extend to other connective tissues throughout the body. So now to where we are today, recent studies have shown statistically significant increases in the risk of aortic aneurysm and subsequent dissection among patients who've been treated with fluoroquinolones. In response to this, the FDA has issued a black box warning regarding this increased risk of aneurysm and dissection with fluoroquinolone use. Again, the exact mechanism by which this occurs is still not understood. However, there are several current working theories. It's been proposed that fluoroquinolones may lead to degradation of the structural components of the aortic wall, which increases the propensity for aneurysm formation and subsequent rupture. So these are the three most prevalent hypotheses for the development of aortic aneurysms in association with fluoroquinolones. The extracellular matrix hypothesis suggests that the fluoroquinolones disrupt the homeostasis of the normal function of the extracellular matrix, which weakens the aortic wall and makes it more susceptible to aneurysm and then dissection. And then sort of in turn with this is the matrix metalloproteinase hypothesis. Is thought that the fluoroquinolones could upregulate the MMPs and lead to excessive degradation of the extracellular matrix proteins and then subsequent weakening of the wall and aneurysm. And then the other proposed pathway is the TGF-beta pathway. This was borne out from genetic studies in the aortopathies such as Marfan's, Ehlers-Danlos, Lewy-Dietz, that suggests that the fluoroquinolones may disrupt the TGF-beta signaling pathway, which is vital in the regulation of tissue repair mechanisms, and this disruption can lead to aneurysm formation. So this is just a model of how the extracellular matrix contributes to the development of aneurysms. The medial layer is where the majority of these MMPs and extracellular matrix tissue are located, and the degradation of this leads to weakening of the aortic wall and then subsequent aneurysm development. And then this slide shows the pathway of the TGF-beta signaling. It's quite complex. It's a very ubiquitous pathway. There's a very delicate balance between the canonical and non-canonical pathways, and any disruption can lead to upregulation of one or the other, and then subsequent increased TGF-beta signaling and disruption in the cell wall or aorta wall homeostasis. So now I'll turn it over to my colleague, Dr. Eckold, to discuss the methods and what we found.
My name is Connor Eckel, one of the other third-year residents. So now having kind of developed an understanding of what was going on a cellular level in the development of these aortic aneurysms in patients who have been exposed to fluoroquinolones, we sought to identify three things, basically. One, which genes are particularly affected by exposure to fluoroquinolones. Two, which things are uniquely expressed within the aortic cell walls or aortic endothelial cells. And three, which genes are common between those groups. One being affected by fluoroquinolones and uniquely expressed in aortic endothelial cells and can serve as potential targets for future basic science research and why those genes make them particularly susceptible to development of aneurysms. So with that in mind, we use what's called a comparative toxogenomics database. This is a large database available through the National Center of Bioinformation Technology with the U.S. Library of Medicine, which allows you to identify keywords or phrases or certain things that you're interested in and runs them through basically the human genome to identify which genes are particularly affected by that certain topic or, in this case, fluoroquinolones. So by running it through this comparative toxogenomics database, we identified 2,296 genes that were particularly targeted or affected in some way by exposure to fluoroquinolones. So that'll be our first group that we talked about, just genes that are affected by fluoroquinolones. This is just another kind of representation of those genes, which kind of lends some legitimacy to to Garrett's portion, where one of those pathways being the matrix metalloproteinases, being things that are particularly affected by fluoroquinolones. And this is just an example of a few of those genes within those 2,000 plus things that we identified. Next, we wanted to identify which genes are uniquely expressed within aortic endothelial cells that are leading to the formation of aneurysms within aortic cells and not necessarily in other arterial endothelial cells elsewhere in the body. Our thought process being that, we've identified that fluoroquinolones lead to increased aneurysm formation in the aorta, but not necessarily anywhere else, such as iliac cells or hepatic arteries and things like that. So we wanted to, using aortic endothelial cells as our control group, this database called the Endothelial Cell Database allows you to compare endothelial cells in one group versus another. So with aortic cells as our control group, we wanted to find a comparison group that could serve as a comparison in the sense that it's cells that are exposed to similar hemodynamic effects or pressures, and could it serve as an explanation of why those cells don't necessarily develop aneurysms after exposure to fluoroquinolones. In this case, we selected iliac artery endothelial cells because they're just downstream from aortic cells and presumptively exposed to similar hemodynamic effects. One caveat here is that, while there hasn't been any identification of increased rates of aneurysms within iliac endothelial cells exposed to fluoroquinolones, this may be due to just that we haven't studied that enough or hasn't been seen, but we were just going to operate under the assumption that iliac artery aneurysms aren't occurring in patients exposed to fluoroquinolones while they are occurring in patients in the aortic cells. So using this endothelial cell database and comparing which genes are differentially expressed between aortic endothelial cells versus iliac artery endothelial cells. This is just kind of a visual representation of that, the red being genes that are overly expressed and the blue being underexpressed. Here, we're able to identify 240 genes that are uniquely expressed in aortic cells and not necessarily in iliac artery endothelial cells. So with those two groups now in mind, we have our 2,000 plus genes that are affected by fluoroquinolones and our 240 genes that are uniquely expressed in aortic endothelial cells. We compared those two groups to find which genes were in common, and that led to the identification of 50 genes that were both affected by fluoroquinolones and uniquely expressed within aortic endothelial cells. Using these 50 genes, we perform what's called a gene ontology analysis. This basically allows you to run a pathway or visual representation through things like molecular function, cellular function, and biological processes to see what's in common between this 50 gene group. This is the visual representation of that mapping of gene ontology. And this is where our findings were kind of novel or unique in that a lot of our research beforehand and literature review identified things like the matrix metalloproteinases, the TGF-beta, and extracellular matrix as important in the formation of aneurysms. But here, kind of unexpectedly, we found that the top 5 pathways that connected these 50 genes, all involved in some way T helper cells and more specifically T helper 17 cells, which we didn't really find in any of our kind of literature review beforehand. These T helper 17 cells are important in recruitment of other inflammatory cells, other T cells and B cells, and pro-inflammatory cytokines that lead to further inflammation and recruitment of things like neutrophils and macrophages. So it kind of serves as a unique finding that maybe this is a good reason of why these cells within aortic endothelial, the genes within aortic endothelial cells that are exposed to fluoroquinolones are leading to upregulation of T helper cells and more inflammation within the aortic wall and more aneurysmal formation. And this is just a kind of a visual representation of T helper 17 cells. This is another sort of pathway that kind of confirms some of those findings. It's called an enrichment analysis, which is basically another way of looking at gene ontology that's less at the specific genes or molecules involved, more at the cellular processes that they're affecting. So using those same 50 genes, we put them through this enrichment pathway, which shows you the top processes that those 50 genes are involved with. And again, you see things like leukocyte tethering, adhesion, regulation of inflammatory cells, which kind of fits with what we had seen with the identification of T helper 17 cells as well. As I mentioned before, we looked at iliac artery cells in particular, given their similarity in exposure to hemodynamic effects and things to aortic cells. One way we could further extrapolate this data is comparing aortic cells to other arterial endothelial cells throughout the body. One in particular that we ran as well was a hepatic artery endothelial, and you can see there just the genes that can be identified that are differentially expressed between aortic cells and hepatic artery cells, which could lead to further studies in identifying which genes are different between aortic cells and other areas that may explain why they're more prone to aneurysmal formation. Further studies, I think this gives us a good target and to look into why aortic cells are more prone to aneurysm formation after exposure to fluoroquinolones. It would be great to be able to run this in kind of a basic science labs and tag things like T helper 17 cells that could serve to identify why this effect exists and kind of form a causal relationship between the two. So we're working on some review papers in literature review and hoping to kind of take it to the next step from there.
Very nice study. Did you see in the other patients who have adolescent and have not been exposed to the fluoroquinolones, the same gene pattern?
That's not something we looked at, I don't think.
And
but,
also the minimum required exposure. 1 day, 1 week, and did you see anything or just the medicine being there causing the problem?
Yeah, I remember, Garrett, do you remember what it was like, how long the exposure lasts and things like that?
It is dose dependent. People who have got more than 7 days are at higher risk, and the risk is it's increased for up to 60 days after exposure.
It's very interesting that the treatments, that there were some studies early on that thought antibiotics could decrease the rise or the increase in size of antibiotics decades ago. And we wonder if this is somewhat connected to that. Those studies never really panned out as far as being effective, but there was some studies that showed that there was at least halt of growth of some of the high-risk patients with aneurysms. Forget the antibiotic, Dr. Burke, you may remember, but there were some of those studies that went on. Any comments from our expert?
Just a basic comment that it's very interesting that you used iliac endothelium as a comparison. I think that's a good idea. It's a very similar type of hemodynamics, but obviously express different cell markers and genetic markers. So congratulations for that. It'd be interesting to see the next steps in terms of human samples and where you go from there.
Scott Mayer, who started the early rat models with this before it went along, came and spoke about 4 years ago. He is the editor of surgical research in the United States and is at the Baby Heart Institute and works with Dr. Joe Caselli, clinically. now he's more of a researcher. But it'll be very interesting to see how T helper cells, we don't know where these 17 helper cells are going to, does it really, where does it work, how does it work? Can you block this specifically? In patients who have, it would be interesting to see patients who have had some sort of immunosuppression where T17 cells aren't effective, do they have higher risk of aneurysms if they're concurrently treated with bartonella? So there's a lot of things that we're going to look at. But this is a novel finding. Where do we go from here? It's going to be up to these guys because these two gentlemen, along with Dr. Zachary Conley, really found this out. And it's amazing what is available through this, what's already been studied. This is not novel lab bench work. This is from databases that have already been presented, it's publicly available, very much like the SEER database. That they cross-reference these, and I was amazed at what they found. Dr. Burke.
Excellent presentation. So I recently attended the SBS annual VAM meeting in DC last week. So there was a presentation from vascular surgeons in Hong Kong. So what are they doing is there's a molecule, pentaglycol, so they're delivering directly, like they're going a catheter-based therapy and delivering the molecule directly into the aneurysm. And they have seen that the growth has like stabilized. So I think so there's a lot of work needs to be done on these lines, like antibiotics or any molecule can stabilize the aneurysmal wall.
I think it's incredible amount of work that went into this and just the thinking to kind of cross these two databases and identify specific areas that are targets is to be commended. So to me, this is really something that has a lot of potential for future investigation, and you just don't know where it's going to take you. So I think it's kind of an interesting. It's really interesting to see how these two data sets can move in the direction that you were not reached on your own.
All right, that concludes our resident research presentations. So, Dr. Sutherland, if you think about this throughout the day, have a cocktail, come up with the winner, and let me know before our presentations today. So, would like to thank some people that go unnoticed a lot. Stacy Simpson, Jenny, Wendy, Tammy, Debbie, Joyce, who all work in our office, who do everything to help us get this stuff together. So thank you so much. And I want to give a big round of hand to those guys. They don't make enough money. I mean, I wish they made 3 times what they did, because they really coordinate the program and make us all successful. So thanks again. All right, so we'll move on to 3 clinical case presentations now. Likewise, we'd like you to grade these in your mind and think what presents maybe the optimal therapy, the optimal presentation techniques, and the outcomes. So we'll start with Dr. Alex Birch with a penetrating neck injury.
Good morning. I'm one of the 4th-year surgery residents. It's an honor to present this case to you guys. This was a lot of fun. It ended up being a multidisciplinary case. We had Dr. Prokowski, Rao, and Samra. So we had vascular, CT surgery, and trauma. So this was a trauma stat. It was a 36-year-old female who had come in with being stabbed with a knife in the left neck close to the clavicle in zone 1. She presented with active pulsatile bleeding. The wound was packed with quick clot and manual pressure was applied. She was GCS 15. Her airway was intact. She had bilateral breath sounds. She had good systolic pressure of 130. Her secondary survey was unremarkable, and she was emergently taken to the operating room. Unfortunately, I don't have any pictures from the actual event, but this is kind of a schematic of what we were thinking. here is essentially where she got stabbed. And it was a posterior medial trajectory. Dr. Samra had his finger on the spine. So we were obviously concerned with having either an arch injury or potentially a carotid injury. So we prepared to go to the OR and performed a median sternotomy. We had Dr. Samra prepped into the field, holding pressure to the wound. We entered the chest, we opened the pericardium, we didn't see any blood, so we dissected superiorly. The innominate vein appeared to be intact. So we continued to dissect into the superior mediastinum. We clamped the innominate artery, which didn't quell the bleeding, so the clamp was subsequently removed. We dissected out the left carotid. Again, we clamped that, the bleeding didn't stop. And then we dissect out the origin of the left subclavian. However, we were unable to actually clamp the left subclavian. We weren't able to get access to it because that's where Dr. Samra's finger was. So what we ended up doing was extending the incision into the left supraclavicular area, connecting the incision to the stab wound. We divided and incorporating the stab wound into the incision. We divided the anterior scalene, but due to the finger, we were unable to isolate proximal control of the subclavian artery. So at this point, we performed a trapdoor incision that was made through the third intercostal space. Here's kind of a diagram schematic of what our incision ended up looking like. This trapdoor incision is kind of the classic exposure for a subclavian exposure. And here, this is what we saw. There was a almost complete transection through the subclavian artery just beyond the vertebral artery. Both distal and proximal ends were controlled and oversewn. But we continued to have, which provided relatively good hemostasis. However, we continued to have venous bleeding coming from behind. And that's when we saw that the vertebral vein was also partially transected. And because it was so close to the spinal canal, it was oversewn with a pledgeted 4-O-proline just to get hemostasis. But at the time, it required manual compression of the aorta to get control. MTP had been activated during that time, but once we had gotten control of everything, hemostasis was achieved. The patient stabilized, chest tubes were placed, the chest was closed, and the patient was taken to the ICU for resuscitation. Postoperatively, day 1, she had some seizure-like activity. An EEG was performed, which was negative for any seizures. She was moving all 4 extremities, but not to command. She had a Dopplerable left brachial artery, which was weak, but she did have cap refill. It was slightly delayed, 4 to 5 seconds. Post-op day 2, she was following commands. She was extubated. Her left arm had full strength. She did complain of some mild numbness in the hand. Post-op day 5, her mediastinal chest tube was removed. Day 8, she was transferred to the floor. Day 10, she really only had any residual paresthesias to the left 4th and 5th digits. Day 11, her last chest tube was removed and she went home day 12. So trapdoor incision is not something that we commonly see or do. About 18% of patients with penetrating trauma to these vessels are in extremis or without signs of life by the time they even get to us. Recently, I guess there's been some research that has sort of shied away from doing trapdoor incisions because they're associated to being more painful, more post-op bleeding, respiratory complications. But more research has been done recently that has shown that about 50% of these approaches needed to be extended to include the sternotomy. The alternative was either a supra or infraclavicular incision, often requiring transection of the clavicle, which required plating. Venous repair of these great vessels is seldom done. Usually they're in extremis, and usually ligation is preferred. And the mortality can rise up to 80% when it's arterial injury or combined lesion is present. Thank you for allowing me a chance to present.
So, if I understood you correctly, you oversewed the subclavian artery.
Yes,
Was
sir.
there any consideration to a primary repair, or what was the status of the artery at the time of the exploration?
So it was about 90% transected, and we were in extremis with MTP activated. So we were really just trying to get control of the bleeding to make sure this patient made it out of the OR.
Obviously, the upper extremity, you didn't have frank necrosis or anything like that. What do you think, or estimated collateral flow kept that arm alive?
The estimated collateral flow. I mean, I think that she got very lucky. You know, ligating the left subclavian is obviously going to be a huge detriment. It could lose the arm. I'm not sure I understand.
So, actually what happens in adults, I think I was involved in this case.
Yes, sir.
So we talked about doing the primary repair. It was, patient was almost on the dying death table, and I talked to Dr. Prakash, should we do a primary repair? I said, Dr. Rao, this patient is dying, and with a MTP, he got 23 units of blood given. I said, that's not a good thing to do right now. And in adults, if you like it, the artery, they have enough collaterals. Usually nothing happens. Whereas in children, you can't like it. You have to do a reconstruction or a bypass. But adults, they have developed enough collaterals around the scapula, around the subclavian artery before and after. So they do survive, they won't have much of a ischemia.
I'd be interested to see, obviously the vertebral artery was involved in that complex. I would be more, are you concerned about, did y'all do any CT scans that shows any posterior compartmental ischemia or infarcts?
So I think when she started showing that seizure-like activity, we all got concerned about that. She did have a CT scan which showed that because we ligated the vein and not the artery, so she was okay from that standpoint. But I think we got really lucky with her having such a good outcome.
That could have been, you could have had almost a subclavian steel type syndrome that creates flow through the vertebral retrograde into the left arm, which can happen. Steve and I did a arch transection the other day, or dissection, where we got in, and the vertebral was separate from the subclavian, and we didn't include it in our, when we debranched. We ligated because we had good retrograde flow. This patient didn't turn the corner very easily. So that vertebral lobe sometimes, especially with atherosclerosis, if you don't get that flow retrograde into the vertebra, you're going to have a real problem.
Congratulations, nice save. I want to get educated. I've been out of trauma for a long time. You guys have one of the best departments, cardiovascular here, and minimally invasive surgery is fairly common for you guys, but it seems to me that you brought this patient to the operating room. Is there ever a role to actually get an angiogram and vascular sweep to see if there's any endovascular intervention can be made rather than actually operating?
So we did try to attempt leaving pressure off the quick clot that was packed in there, and it immediately turned into pulsatile bleeding. So she wasn't stable enough, although that is that is one of the approaches that people will take if they're stable, is you can get a CTA and do an endovascular approach potentially. I did read also that some people will also use like a Foley catheter or some kind of Fogarty to tamponade. But she was doing well, but very tentatively. So I think, if we had waited, she probably wouldn't have made it.
Dr. Z, the EMS crew, the hospital responders, the first responders told us at the scene, the blood from the stab was going through the window of the house. So clearly pulsatile, the girl was very confident. That's like a hard sign. They put the quick clot back, and then in the trauma bay, we try to, sneak and see what's going on. And I could see that they moved the quick clot out, and suddenly my finger was almost to the spine. But to the spine, and there was pulse that week, so we didn't want to waste time. It's a hard sign. That's why.
Yeah, poor
But I
Greg is
think
there to
it's
do an angio.
There's a modality to go for the angio if you have time with a roadmap. It's good for the junction injuries for our vascular colleagues. They told us a lot of that, but in this scenario, it was a little bit more tenderness.
Yes.
After you stabilize and save the life of the patient by ligating the subclavian, was there any thought to reimplant the translated part to the aorta?
In fact, we saw her post-op. She has actually no signs of ischemia.
Okay.
And then it's also left hand. It's not like she's using too much. Right hand people use it more. And then so we wanted to study, and she's also psychiatrically not that stable patient. And so she did not have any symptoms. So but eventually if she develops some ischemia, some weakness, we restudy her and we can do a bypass.
No, I mean the same time that in the same scene when you have saved the life, the patient is stable now, even before waiting to see if there's any symptom or not, just implant it in the aorta.
If she becomes symptomatic.
So the transection was distal to the vertebral arm.
Yeah.
So implantation was probably not an option. So when I do implantations or transpositions, we transect the subclavian toxin. So we were much more worried about arm ischemia than Dr. Burks there was no feeding from the vertebral artery because we ligated distally. So all the collateral flows through the dorsal and scapular fibers. So absolutely.
Great. Dr. Burke, I'm sorry, one more question.
Good case. So from the coverage of left subclavian, nowadays we see a lot of like blunt thoracic aortic trauma. Usually the trauma happens at the isthmus, like very close to the left subclavian artery. So back in days, the treatment was just to cover the left subclavian, and in case the arm gets ischemic or the patient develops vertebro-basilar symptoms, you go ahead and revascularize. You do a carotid subclavian bypass, or you do a subclavian transposition depending on the anatomy. But nowadays the guidelines are that if you have expertise to revascularize the left subclavian right then and there, you do it first and then you cover the left subclavian region. Means either you do a subclavian transposition, or you do a carotid subclavian bypass, or you do a laser fenestration of the thoracic stent graft to perfuse the left subclavian. So the guidelines have changed. So if you have expertise available, you do the revascularization and then you cover the aorta.
The guidelines have changed for almost all descending thoracic aortic pathology, and there's hardly any reasons for open now. They're almost all endovascular. So I'm happy to turn over those type B dissections to our vascular colleagues, where I had to sit up with those for quite some time. For the gray hairs in the audience, two subclavian injuries that I remember here at LSU. John Wilder Baker and I were involved, and he's now at Tulane. He's a professor at Tulane. Had a through and through at Conway, through and through injury of the left subclavian with an AV fistula. The patient did lose his arm. We did save his life and did lose his upper extremity, but the guy is still here, and I still hear from him. And then the second one was a senator that arrived in extremis here with a 22 bullet wound through the proximal left subclavian. And believe it or not, Dr. McDonald, Dr. McMillan, Dr. Jane Eggerstadt, and all were involved with his care, and he's subsequently still politicking right now, and I won't mention any names. Okay. The next case presentation, Dr. Connor Eckholtz with a mesenteric ischemic case.
Okay. All right. This is a case I was involved with Dr. Sitt, as well as a few of our other general surgery colleagues, Dr. Savoy, Dr. Morano. And I know that much of the residents will know about this case as well. A lot of people were involved, and ultimately, has come to a pretty good outcome for this patient. This is an interesting case for a number of reasons. One, this patient had was born with bacterial syndrome and had a number of surgeries throughout her life due to those syndromic defects. And then it required a lot of help from our critical care people as well to ultimately bring her to a good outcome. So this was a 23-year-old female who came in with to the ER here with worsening abdominal pain of acute onset as well as nausea and vomiting. She came in around 9 or 10 p.m. at night on a Saturday on the 20th of May, and she said her symptoms had started earlier that morning and just progressively worsened throughout the day. She was distended, couldn't hold anything down, and that was about the time she came to the ER. Her medical history was significant for bacterial syndrome, as mentioned. Within bacterial syndrome, she had issues with cardiac. She had chronic congestive heart failure with an EF of about 45 to 50%. She had suffered from renal disease throughout her life. She had chronic uretopelvic reflux, and that had led to persistent hydroureter, hydronephrosis, multiple episodes of pyelonephritis that ultimately led to her having bilateral nephrectomies about 2 or 3 years ago. So she was end-stage renal on dialysis through an upper extremity fistula. She also had an imperforate anus at birth that required creation of a diverting ileostomy. Interestingly, most of her colon was actually retroperitonealized that we discovered during her case and just hadn't been ever used before. So she was pretty dependent on just all of her small bowel and had a diverting ileostomy. She also was born with a tracheoesophageal fistula that was repaired in infancy, and she had also had undergone urogenital reconstruction as well. She had previously been admitted to the hospital multiple times, most recently about 3 days prior to this presentation with just a recalcitrant C. diff infection for which she was on oral vancomycin. This was a C. diff infection of her small bowel that she was actually undergoing workup for fecal transplant as well. Some of her surgery history there is mentioned, and medications for her renal disease, as well as she was on midodrine a few times a day for just chronic hypotension. So when she came to the ER, she was ill-appearing, she was tachycardic, she had the abdominal distension and diffuse tenderness as mentioned, and she was borderline peritonitic at this point at the time surgery was involved. You see some of her labs there. She was pretty significantly anemic with a hemoglobin of 5.7. Her lactate was 3.7. You see some of her metabolic panel there consistent with a patient with end-stage renal disease. This was her CAT scan that was obtained at the time of her presentation. You can see on this CAT scan coming up around the stomach here is this area of free air and concern for a perforation on the anterior and posterior portion of the stomach, as well as significant dilation of a small bowel, the largest up to about 7.3 centimeters. It's a little blurry. Let's see if we can see that area on the stomach a little bit better. So there's kind of these few areas of concern for free air around the stomach, and given that she was peritonitic, essentially had worsening vital signs, on clinical exam she was distended, in a lot of pain, and the CT scan findings of concern for perforation in free air, we elected to take her to the operating room for an exploratory laparotomy. At the time of her first operation, upon entrance to the abdominal cavity, an extensive lysis of adhesions was performed up to 4 hours. Both the anterior and posterior aspect of the stomach through the lesser sac were explored, but no perforation or injury was actually identified to the stomach. A small liver tear was created this time, but that was able to be controlled with some hemostatic agents. In all, the small bowel was able to be run from the ligament trites to her endoleostomy, and no real perforation or cause of the free air was really able to be identified, but she did have this kind of strange torsion of a lot of her small bowel around this thick band of fibrous tissue that extended from basically the point of her SMA up to almost to the ileostomy site, which a lot of her small bowel was twisted around. So we were able to reduce that, and there was some duskiness to the area of her small bowel as well in the distal ileum. She had worsening hyperkalemia and issues with blood pressure, hemodynamics at this point, so we elected to place an EP there and get her back to the ICU for further resuscitation, and the goal of getting her dialyzed before we go back to the go back to the OR for more definitive management, and see if these areas of duskiness would declare in terms of a ischemic bowel. On return to the ICU on that first day, we were planning to go back within about 12 to 24 hours for another exploration, but Within the first 4 hours of her return to the ICU, she was increasingly distended. She had a significant amount of bloody output in her aphthera wound vac. And due to concerns for ongoing bleeding, we actually took her back to the OR within about 4 hours of that initial operation for re-exploration. Interestingly, in that second surgery, we really didn't find anything actively bleeding to explain all that. We found a few small mesenteric bleeds that were cauterized and controlled, but the liver laceration was hemostatic, and otherwise her bowel appeared about the same from that initial operation. So we replaced Ev there, got her back to the ICU. This is one area that in this initial management I think was an area for improvement that I think may have contributed to some of her issues as well, in that we would have liked to get her on CRT, or continuous renal replacement therapy, early on, just because of her hemodynamic compromise and need for dialysis due to worsening hyperkalemia and lactic acidosis. But I think one of the issues in the MICU at that time is they didn't quite have the staff to run CRT early on, and that's been an issue in a lot of our patients lately, is just nursing staff availability, and it to run requires a one-on-one in CRT, and I just don't think they could do it that day. So she ended up getting SLED, or sustained low efficiency dialysis for some, just kind of a middle ground between traditional hemodialysis and CRT in patients with a little bit more hemodynamic compromise. Usually it's run about 6 to 12 hours, but in her case, due to ongoing increased pressure requirements and need for fluid, she only got about 3 hours of dialysis on that first day. This is one point that I was looking into as well in the terms of how we fluid resuscitate patients who are end-stage renal. Oftentimes I think we learn, or we're taught that to be pretty conservative in our fluid management in patients with end-stage renal due to concerns that we can worsen respiratory distress or pulmonary edema and cardiac issues in patients who already have some underlying cardiac disease. But a lot of the research I looked into this shows that there really is better outcomes when patients are treated with aggressive fluid management and kind of the traditional fluid resuscitation guidelines, just like 30 cc's per kg of fluid and things like that in our initial resuscitation. So I think she really was under-resuscitated early on due to just kind of hesitancy in replacing her fluids. She was eventually able to get started on CRT the next day, and overall she was actually run kind of net negative in this time. They were keeping her net even on the CRT machine, but due to ongoing GI losses from her aphthera wound, her NG tube, her overall fluid status was actually down. So I think that's one area that we could have improved in her fluid resuscitation early on. One thing I also learned in kind of looking into this case was a therapeutic plasma exchange was used in this patient. An entity that I wasn't too familiar with before all this was something called TAMOF, or thrombocytopenia-associated multi-organ failure. Her platelet count had precipitously dropped during her admission from like the 120s, 130s on admission down to like 40s and 50s. So she was significantly thrombocytopenic. So she received a therapeutic plasma exchange, with the thought process being that exchanging her plasma as well as in removing some of the toxins in blood as well, and that's shown better outputs in patients with this entity. That it's kind of on a spectrum of things like DIC and thrombocytopenic purpura that you can exchange plasma and hopefully lead to some better outcomes there. She also had concern for a cardiac event during this time. Her troponins were elevated, and then a repeat echo the next day showed that her EF had decreased to about 10 to 15%. So during this time, she got a fair bit worse. She required increasing pressor requirement. She was on 4 different pressors. You can see there: norepi, vasopressin, dobutamine, phenylephrine. She had worsening lactic acidosis, and our ability to go back to the OR was really delayed due to her hemodynamic stability, or instability, I should say. Her lactate rose. I think the highest it got was that first night was up to 16. You see the trend over a number of days there that it did eventually come down. But our ability to get her back to the OR early on was really inhibited by her hemodynamic instability. And she really couldn't come off the CRT machine for any prolonged period of time due to just issues with hyperkalemia as well. Eventually, we were able to get back to the OR on hospital day 6. At that time, you can see an image there of some of her bowels, that she did have multiple areas of contiguous bowel ischemia throughout her small intestines. In all, before we started this case, she had about 200 centimeters of small bowel in total. And, you know, we talked a lot about trying to conserve as much length as possible and trying to prevent a short bowel syndrome in this patient, but she did have areas of just frank necrosis that we couldn't leave in this initial operation. So we did resected 3 areas of bowel, including having to take down her ileostomy and take out a portion of that as well. So we left her in discontinuity with plans to go back to the OR and with further resuscitation, and ultimately do our best to preserve as much intestinal length as possible. She was able to go back a couple days later. She essentially had 3 areas of bowel that we had left that were each about, the first one was like about 90 centimeters, 50 centimeters, and the last one I think was in the range of like 40 or 50 as well. So when we took her back to that last time, ultimately when she had stabilized and was stable to go back to the OR for reanastomosis and creation of another endoleostomy, we talked about preserving as much length as possible. We did resect one more portion and just created one anastomosis, leaving her with about 145 centimeters of intestine by the end of it. In terms of trying to prevent short gut syndrome, things we can do, in this case, we wanted to preserve as much length as possible, so we elected to create a hand-sewn end-to-end anastomosis rather than like our traditional like side-to-side stapled anastomosis that we would do. When it comes to preventing short gut syndrome, there's procedures that focus on maintaining as much intestinal length and absorptive area as possible, and then when it comes to the postoperative period, prolonging transit time as much as possible so that we give her the best opportunity to absorb nutritions, and with the ultimate goal of her making her nutritionally independent of TPN. So the rest of her course, she's actually still in the hospital now, so I know a number of people are still seeing her and are familiar with what's going on, but ultimately she was able to come off of CRT and back on her normal dialysis. She was able to start 2 feeds and was extubated, and now she's on the floor and she's actually off TPN, and she's tolerating a diet now at this point. And she's on things like Lamodal, as well as some other supplements to try and prolong her absorptive time in her intestines, as well as prevent things like acid hypersecretion, cholestasis, liver disease, and give her the best opportunity to avoid the chronic effects of short bowel syndrome. And just to comment on Vacterl, it's kind of a heterogenetic disorder in that the amount of times it shows up in births is between like 1 in 10,000 and 1 in 40,000 people. And it's difficult to diagnose because it's such a wide range of defects that don't necessarily fall within one genetic thing, or one genetic cause, I should say. So it's differentially diagnosed, and you can see that each of those defects presents in different proportion in those patients. So this patient suffered from a few of these, and usually it's at least 3 of these before you call it Vacterl syndrome. Looking back through her earliest notes that I could get back to in the chart were from like 2011, 2012, and trying to figure out why she had this kind of underutilized colon and had undergone all these previous uretopelvic procedures as well. It seemed like she had some poor follow-up early on, and it seems like she was meant to have more procedures for utilization of her intestines and things like that, but I think that was an issue in her earlier life that she didn't have great follow-up and ultimately led to her current situation with her surgical history. But that's all I have.
What you alluded to with the management, I helped with that second procedure, and I about lost my mind in the procedure because there was clearly dead bowel, and it was clearly in local state and malperfusion because there was patches in different areas. And when you hear the curtain, the CRNA, a bunch of buttons on the drips and what's going on there, you know, just starting another pressor, going up on my Vivo. And I'm like, well, have you used fluid? No, because they weren't in the ICU either. That was when I was like, flood her, please God, give her all the fluid you could possibly find in the room right now, because that's what she needs to save her bowel. Like, what's the point in worrying about her being on dialysis if she's dead, right? I mean, who cares? We can dialyze her later to get some of that fluid off. She's intubated, she's got an open abdomen, don't worry about that right now. And it's just like that, like you said, because they were trying to worry about her kidneys, which are already not in her body. Yeah, exactly. So they were trying to worry about her being on dialysis and not worrying about what was actively killing her at the time. Once it seemed like, at least I didn't keep going after that, but once they started actually giving her fluids, things got a little bit better. You know?
I'd like to look at the occurrence. We have a rash of AKI. As a matter of fact, the task force is now being initiated in the hospital because of AKI infections, just like you. You look at the early use of alpha agonists, vasopressin, norepinephrine. We treat that as first line prior fluid. Really transfusions or crystal oil or a combination of both. You get the preload up prior to using these alpha agonists. And I think we're seeing that because we just use them earlier. Likewise, I remember 10, 20 liters of fluid later, in blood and crystal oil. We still have a bloated patient, huge. They had plenty of preload. We started alpha agonists too late back then. We were afraid of vasoconstriction, mesenteric vasoconstriction. So we've kind of turned the tide.
So you presented this as a mesenteric ischemia patient. From the presentation, it looks more like a partial closed loop obstruction or something along those lines, that it was not a, when I think of mesenteric ischemia, I'm thinking of more proximal. Did you guys evaluate the proximal mesenteric to SMA and the other vessels to ensure that they were intact and appropriately perfusing the area that was there, or is this all mechanical, or what was your impression?
I know at the time, I wasn't at the first operation, but I know at the time she did have Doppler signals and a palpable good pulse in the SMA, and on her initial CAT scan there wasn't really any concern for any ischemic compromise from like the takeoff of those main vessels. But yeah, I think this really was a product of under resuscitation, high doses of pressors leading to a more kind of a microvascular compromise rather than those larger vessels.
Testament to the diligence of your ICU care that she's where she is. So congratulations.
Dr. Sutherland, I would like to ask your opinion on, there has been literature out that in trauma and acute care world, in the ICU setting, patients are over fluid loaded as well. And there's a concept of de-escalation or diuretic therapy after they are resuscitated. So it's interesting that we find a lot of API versus fluid overload. That's also new coming up in the literature. The surgeons tend to sometimes in the ICU setting overload the patient with fluids as well. So they talk about diuretics, the D's of resuscitation as opposed to 3 or 4. So that's something also. I wonder what's your take on that?
So my experience has been that we don't see the same fluid overload in a crystalloid restricted resuscitation. So if we early and aggressively move to blood and blood product resuscitations, this becomes much less of an issue. So I start major resuscitations with less than a liter of crystalloid, and I try to talk to my ICU colleagues, my anesthesia colleagues, et cetera, to say, we really want to limit crystalloid in this patient. This patient is a great example. We started out with hemoglobin 5. You've got nowhere to go but up. Plenty of room to resuscitate with the FFP and blood products in order to give a better balanced resuscitation that has less of a capillary leak, less of translocation of crystalloid into the lungs and the other tissues. So that's been my experience. And that's what we really try to focus on, is reducing the problem. So if you don't flood them with crystalloid, then you don't have to worry about the diuretics on the back end. But in the circumstances where they do get a lot of fluid, we do try to bring diuretics in to be an adjunct to help reduce the interstitial fluid.
Great save, and congratulations for the team effort that they have saved the life of this young person. You do not need to worry about the short bowel syndrome, and more than 80 centimeters of bowel will prevent any problem. I have 145 centimeters, so that's not be a problem. And if you have a problem, a small bowel transplant will be the future for this patient. Congratulations again, wonderful to say.
You explained, or you talked about a single kind of band going up to, along with ileostomy up to the abdominal wall. Is that what you described?
Yes, sir.
Okay. Did the ileostomy and the part proximal to it, was that the dead part?
It was the second time we went. It was kind of dusky appearing at the first go.
Was it all, did you get the impression that all of that distal small bowel ran off one single vessel coming up along, like it looked like a really long string? Because this patient may have had like a type 3B atresia at birth, a Christmas tree deformity, and that would leave them with, you have a missing piece of bowel, if the valve would get big, they do an ileostomy, they wouldn't come back later and hooked up or built an anus if she didn't show up.
Right.
But the entire small bowel, or most of it, or a lot of it, might be dead off one vessel, which is very prone to infarction. It's also very prone to low flow states, and they do get a lot of obstructions. So I just wonder if there were some more anatomic problems that maybe.
I think there definitely could have been, because when we talked about maybe taking down that band or changing things, or taking down that adhesion, it really did appear that that was the main blood supply to a lot of it, and we would have potentially killed off more of her intestines if we tried to do that. I think.
Where the ileostomy was coming out to, the bowel had kind of torced around the ileostomy itself. And so I think that also led to kind of this chronic obstruction that this lady had. And I think from the mesenteric ischemia standpoint, I think it was a low flow state. I think it was a no mesenteric ischemia that with the obstruction and with all the bowel dilation, it just compounded the problem and being on poor pressors and being dialyzed. That just all led to this patchy necrosis that we ended up having to resect multiple areas of the bowel.
You get dilated bowel, you get increased tension in the wall, decreased perfusion, and you get dehydrated because you're vomiting, and you're on dialysis, and you're all this stuff, you're just kind of,
The residents forget that, and I forget, that vasopressin was used for massive GI bleeding. That it's such a strong alpha agonist. When we use it, and don't think about something, we use it in the heart room all the time for vasoplegia and SVR problems. We forget why they start having diarrhea, potentially ischemic problems. Thank you very much. Great job.
Last but not least, we have our one final clinical presentation, and we will have a 15-minute break. So we'll limit this last case to about 20 minutes. It's Dr. Subhadeep Paul, robotic wedge resection that we did robotically, along with Dr. Larimore for a carcinoma, or excuse me, a melanoma.
All right, so I'd like to start by thanking everyone listed on this slide. This was a collaborative joint effort between the interventional pulmonology team and Dr. Chambers, the cardiothoracic team, Dr. White, and as well as the surgical oncology team and Dr. Larimore. And thank you to Dr. Marano for helping me with understanding the literature for the metastatic melanoma. Starting off, our patient was a 66-year-old Caucasian male with a history of hypertension and left eyelid squamous cell carcinoma that was previously excised, who initially presented to the surgical oncology clinic for a diagnosis of malignant melanoma of the right anterior chest wall. Patient reported that he first noticed this lesion 2 months ago, and it had been ulcerated and rapidly enlarging. This lesion was actually excised primarily at the outside hospital in February of this year, and the initial pathology from those reports showed a pedunculated spindle cell neoplasm with melanotic features. This case was sent for further review with dermatopathology at the Joint Pathology Center and confirmed to be a T4B lesion with negative margins, however, the closest deep margin being 4 millimeters. The patient later on developed a right axillary lymphadenopathy, denied any systemic symptoms of fevers, chills, night sweats, no weight loss, no loss of appetite, but some generalized fatigue. In terms of the surgical history, he had the right chest wall mass that was excised earlier this year and a left eyelid squamous cell carcinoma. Of note, he was a half-pack per day smoker for the last 35 years. On exam, he had the well-healed incision to the right chest wall from the prior excision. He did have a palpable axillary lymphadenopathy on the right side, and on skin exam, he did have a left popliteal fossa skin lesion that was noted to be approximately 2 centimeters, raised, nodular, and a discolored lesion. Regarding his preoperative workup, so we had the pathology from the outside hospital that showed the T4B pedunculated spindle cell neoplasm with melanotic features. On further path review, there was a deep microsatellite tumor nodule closely approaching the deep margin. And given that he had this palpable axillary lymphadenopathy, an ultrasound-guided core needle biopsy was performed here, and that was indicative of metastatic melanoma. His BRAF gene was negative, and he underwent a staging PET scan that showed concerns for a FDG-avid lesion 1 centimeter and right middle lobe of the lung, concerning for metastatic disease. The complete staging, clinical staging for this patient was a T4B N3C M1B lesion, and his case was discussed extensively at the Multidisciplinary Tumor Board here. And the plans per the decision between the surgical oncology team as well as the medical oncology team was to proceed with neoadjuvant immunotherapy and followed by metastasectomy for his oligometastatic disease of the right chest wall, re-excision given the close margin, the right axillary lymphadenopathy that was now present, as well as a right pulmonary nodule wedge resection, and given the findings on physical exam of the lesion on the left popliteal fossa, a wide local excision of that lesion. So he underwent 3 cycles of nivolumab and relatlimab preoperatively, and he had a staging CT scan before he had surgery that showed an interval decrease in the size of that pulmonary nodule that was first noticed. In regards to the decision for the perioperative therapy, Dr. Graham, oncologist, referenced a study here, which was a clinical trial published in Nature for resectable clinical stage 3 and oligometastatic stage 4 melanoma, where they compared relatlimab and nivolumab combination immunotherapy to nivolumab monotherapy by itself, and showed improvement in progression-free survival. And patients typically had 2 cycles preoperatively of neoadjuvant therapy, followed by resection, then a 1-year course of 10 cycles of adjuvant immunotherapy. The primary endpoint in the study was complete pathologic response rate, and 57% of the patients in their study had a complete pathologic response. 70% of patients had a overall pathologic response rate, and 57% had a radiographic response rate. This is the preoperative CT or PET scan here, and this will show the right axillary lymph node FDG-avid area first, the arrow sign here, and then followed by the right chest wall lesion that was previously excised there, and then lastly the 1 centimeter right pulmonary nodule. And then this is a interval CT chest after the patient had received the immunotherapy preoperatively 3 cycles. That shows an interval decrease in the size of the right pulmonary nodule that should be shown right here. In regards to operative conduct, the operation was started by the interventional pulmonology team, where they initially performed an intraoperative CT scan and uploaded these images into a navigational planning software to create a pathway to the right middle lobe lung lesion. They transferred the data to the ION robot, and an initial anatomic survey was performed with a standard bronchoscopy, followed by placement of a robotic bronchoscope, and they had a pre-programmed navigational map that they had created. And using shape-sensing navigation, the robotic scope was then advanced through the airways to target the lesion of interest in the lateral segment of the right middle lobe. And this is an O-arm here, and this is the ION robot that they utilize. Once the guide sheet was positioned appropriately, a fluoroscopic image was obtained using the 3D O-arm that confirmed the position of both the lesion and the scope, and these are intraoperative pictures of their localization. And a transbronchial needle catheter was utilized, and a combination of ICG and methylene blue was mixed in with the patient's blood and injected to the lesion of interest in the right middle lobe and confirmed under fluoroscopy. In regards to the thoracic surgery portion of the operation, we proceeded to then perform a robotic right middle lobe wedge resection. We used a 4-port technique with 3 8mm ports and 1 12mm port. We utilized intraoperative Firefly to visualize the lesion that had been injected with ICG. And of note, the lesion did show evidence that it had decreased in size with active response to the immunotherapy, like we mentioned. And we utilized a 45mm Sureform stapler to perform a wedge resection of this lesion. Intraoperative frozen section was indicative of a small focus of tumor at the wedge, but mostly areas of fibrosis were present. And lastly, the surgical oncology portion of the operation, we started with performing a wide local re-excision of the right chest wall primary site with using 2 centimeter margins, full thickness. We then performed a right axillary lymph node dissection, visualizing the axillary vein superiorly, the chest wall medially, latissimus dorsi laterally, pec major and minor anteriorly, and subscapularis and latissimus dorsi posteriorly. Throughout the operation, we ensured that we identified the thoracodorsal pedicle as well as the long thoracic nerve and confirmed both using a nerve stimulator. We excised several enlarged level 1 and level 2 lymph nodes and placed a 10-flat JP drain. We also performed a wide local excision of the left popliteal fossa cutaneous lesion. In regards to the pathology from this operation, so from the right middle lobe wedge resection, areas of focal, pleural, and subpleural fibrosis were present, no malignancy seen, and then in the right anterior chest wall, there's no residual malignancy seen from the prior excision. In terms of the lymph nodes for the right axilla, 24 benign lymph nodes were noted, no malignancy, and then the left popliteal fossa lesion had nodular basal cell with overlying differentiated squamous cell, a collision tumor with negative margins present from that standpoint. And so from the pathology, we see that this patient truly did have an apparent complete pathologic response from the neoadjuvant therapy that he had underwent. In regards to the postoperative course for this patient, he was admitted to the ICU for close monitoring overnight and did well. Post-op day 1, he was transferred to the floor, his chest tube was removed, and he was subsequently discharged the following day. He has since then been seen in surgical oncology clinic and noted to be doing well. Drain has been removed, and the plan is for the 10 cycles of adjuvant immunotherapy. In regards to metastatic melanoma, historically these patients have had poor prognosis given the aggressiveness of the disease. The treatment paradigm and landscape have changed dramatically with the advent of these molecular targeted agents and immune checkpoint blockades that were utilized in our case in both the neoadjuvant and the adjuvant setting. Surgery is indicated in these patients, but they have to be carefully selected with resectable disease and patients who would otherwise be good surgical candidates. Common sites of metastasis include lung, liver, CNS, GI tract, adrenal gland, bone, and distant skin. And indications for surgery include ability to have complete resection of oligometastatic disease, or if there's a standpoint from the palliation from complications from metastatic disease if they have ulceration, bleeding, or obstruction. Typically, these patients should be presented at a multidisciplinary tumor board with input from the surgical oncologist as well as the medical oncologist. And ideal candidates for surgery include patients with limited disease, who have long-term disease-free interval, slower tumor growth, and one key point is that they have good response to the initial systemic therapy that they underwent. And the response to the systemic therapy is prognostically useful in selecting patients for metastasectomy. Neoadjuvant approaches using these targeted therapies such as BRAF inhibitors and immune checkpoint inhibitors, anti-PD-1, PD-L1, anti-CTLA-4, are effectively used to downstage tumors, improve resectability, and improved outcomes for these advanced stage melanomas who are undergoing plans for a curative intent treatment. And additionally, there's a phase 2 clinical trial where neoadjuvant pembrolizumab was shown to improve event-free survival in stage 3 and stage 4 melanoma. And at 2 years, the event-free survival for neoadjuvant pembrolizumab was 72% and 49% for adjuvant pembrolizumab. This provides additional support that perioperative immunotherapy in these patients who have resectable melanoma is indicated and is now like the standard of care. Thank you. I'll take any questions.
Very interesting observation. You know that in the hepatobiliary, when we give neoadjuvant chemotherapy and immunotherapy, and it shows a response, but when we take the specimen out, still there is a tumor cell there. So we insist in following this patient with surgery that you show me the pathological response complete. There was no tumor cell there. So it may change completely the future of addressing these tumors in the future. Is your study the only study which has showed complete, or there are other studies which have showed really complete response?
So yeah, in the study that Dr. Morano talked about, there's been numerous studies that have shown that neoadjuvant immunotherapy, 57% or so patients can have a complete pathologic response. So, yeah.
PD-L1 cancer, lung cancer patients that have penetration more than about 15% of their genome is PD-L1. I'll get complete response almost with some of the lung cancers that are, immunologic response. So,
Fantastic presentation again. Yes, we get some very dramatic responses with immunotherapy. We haven't really followed these patients long enough now to know the durability, but the hope is that they'll be durable. Melanoma is one of the rare cancers that can just disappear for no reason. There are very well documented cases of people with metastatic melanoma where it just melts away and is gone. Renal cells and other. Whenever we develop cancer, the body generates an immune response against it. These checkpoint inhibitors facilitate cell death by the immune system. So there's a balance between the body's response to malignancy with an immune response, and the cancer almost always wins. But I think what we're doing with immunotherapy is changing that tide. So we get some very dramatic responses, and I think Dr. White would agree that in beating this gentleman, there was every reason to be aggressive. This guy was a runner.
He smoked 2 packs a day, but he ran 7 miles. And I said, "Where'd you get that from?" He goes, "That's my shirt." I said, "Really?" Because you look like an innocent of this patient. Yeah, doc, I run 7 miles a day. Doesn't give me a break here.
So this is a really impressive presentation of multi-specialty collaboration and engagement with management of the patient. So I commend you on that. My question is, what do you tell this guy, post-op, to expect? I think that's my question.
We thought we had Jimmy Carter. He thought he was going to be gone 5 years ago for metastatic melanoma.
So, great question. I think the literature shows that you still have to follow these patients serially and make sure, although there is good data to suggest that, they can have several years of disease-free survival, they're still at a risk for having a recurrence of their melanoma, and I think they should still be followed very closely with physical exams. In some instances, they even recommend that serial imaging too. So, I think.
A lot of cancers follow the same pathway with neoadjuvant therapy. Some stage 1 gastroesophageal cancers that are treated with neoadjuvant therapy, 30% of those will have no tumor in their specimen. The patient said, "Well, why did you take it out?" That's a good question. Why did we take it out? Is there any role in the future for, with advances in immunotherapy, to follow these with PET scans to see if these recur, and if they do recur, is the prognosis worse?
Yeah, no, I think that's always the question. Having a pathology come back as definitive evidence that yes, you've done your part. You can confirm that lesion that we saw in the PET scan. There is no focus of cancer. Without doing a complete resection of it, you can't definitively say to a patient. And I think with imaging, there's always a chance that what if there's something residual there. I think it would be tough.
Less than 8 millimeters. Yeah. PET scan really has no good function as far as surveillance.
Really congratulations. What's really so impressive that these patients responded so well, but what is even more important to me, what I see in future new innovation and technology, localizing lesion to basically perimeter, where intraoperative, you're using CAT scan, using robotic bronch, all the technology to delineate the anatomy, because it's not uncommon, at least in the liver literature, that what we call it, given into chemotherapy, what we call it vanishing liver lesion. And in reality, when you go back in and removing them, literally you can find tumor in every one of them. Rarely ever you see clean lesion. But with this immunotherapy and better chemotherapy, likely than not, that the lesion will be sterilized. But technology finding these lesions, sometimes you have ultrasound in your hand, you cannot see the ultrasound, but incorporating all these images, superimposing, it actually will guide you to where exactly where the lesion is.
And with Firefly, they pulled the CT scan. It took me aback. We got the robotic bronchoscope ready, and I asked Cynthia, what the hell is this machine? This operative CT scan, they brought this C-arm, and I thought it was going to be a C-arm. I was amazed at the resolution that we were able to see, how they were able to put this in with ICG and mix it with some blood and some methylene. We couldn't feel this obviously with the robot, but even localized and visually without Firefly, we could have done it. So, last question.
I think the $1 million question will be the timing of surgery. That when, how long you are going to observe this patient. From one side, you can be sure that 100% you get the response, but at the same time, it may be care. So, it's the patient safety and that when you are going to do the surgery.
A little concerned we're waiting too long.
Yeah,
Yes.
the patients in the trial that he quoted got 2 cycles of the neoadjuvant and then were operated on. Just for logistical reasons, our gentleman got 3 cycles. But he's still getting 10 more cycles out. It's a very fascinating question you had about whether to go ahead, these people need to be resected. I mean, that's how we determine that they have a complete pathological response.
That's exactly right.
That's
diagnostic procedure, not just
similar in triple negative breast cancer, we give neoadjuvant therapy, and those patients, don't ask me how I know this, but they do much better if they have a complete pathologic response when they have their surgery. But that's how you determine that they've had a complete response.
Last question, Dr. Mann.
I mean, if I had to pick, I think you know which one I would pick, which one. But this, I love hearing this case. It gets me gassed up, even though I wasn't even involved in it. Because it makes the Da Vinci robot, the stuff that they're doing, look kind of archaic almost, the stuff that the pulmonologist will do. But I think what you're going to see is, so as far as the watching and waiting, the obvious answer is rectal cancer right now, right? So they're treating people, and then they're just doing sigmoidoscopies and seeing if they have disease. And there's some data, some Kettering that looks at some of these, because they've had a couple of years worth now, where I think with 9, or I think it's somewhere around 20% of patients, somewhere in the high teens, have local failure and end up getting surgery. So and then a smaller percent have distant metastases from it. But for someone like these, I think what you'll see is more of the therapy will switch to neoadjuvant, right? This is the first time we're doing neoadjuvant for melanoma, even though some people were just doing it sort of just as tradition. If you look 7, 8 years back, it was IL-2, interferon, that kind of ridiculous stuff. Don't say that stuff in your boards. And like relatlimab is a LAG-3. I don't know the pathway to LAG-3. That's a new immunotherapy essentially that they combine with this. So it's just going to keep going that way. So eventually, you're right, we'll just not operate on it.
Yeah. It's interesting. I talked to the CEO of the 2 of the robots and the second man. The CEO has actually got a degree in applied mathematics from Stanford, and he's actually just a brilliant man. And he said, Keith, what do you think about lesions like this with therapy through the bronchoscope to treat these lesions early on? And I think that's going to happen. You take a 1 centimeter lesion that's located bronchoscopically, that's accessible, and deliver therapy there, whether it's radio frequency, immunotherapy, in addition to systemic therapy. So it's going to be interesting to see how that pans out. We usually finish on time. This has been great. So thank you. We're going to take a 15-minute break, come back, and then Dr. Sullivan's going to deliver this.
fine, I'm sitting here. They are, well, they're on the.
Okay, good. They're on the two.
They're on the,
Right.
If you guys can hear us out there, come on in. It's like once you break for church, you just can't get people back in. There we go.
Yes.
Yeah, tell them to come on in. Let's get going. Let's everybody, let's take our seats and let's get going. Jenny told me we had to be out of this room by 12:30, I think. So. Just like home, nobody listens to me. All right, without further ado, we'll finish the next hour or so with our guest speaker, Dr. Mike Sutherland, who I'm very honored to have today, and I will start, prior to his introduction, with just a history of the Abramson Lecture. You know, I hate that someone is represented by a picture on the wall by my office that nobody knows who they are, and I went through this Abramson Lecture 4 years and never really knew who he was, and the things that he did in Shreveport, the things that he did regionally, nationally. He also, just like Dr. Sutherland, was in the armed forces and actually spent active time in Europe. So we'll proceed with what he did for us. So Dr. Paul Abramson, this is denoted here in a Shreveport Times picture from roughly around 1958, just a year prior to him passing away at 53 of a massive MI. His dad passed away of similar pathology. But he represented a very growing time here at LSU when the number of cases were dramatically increasing. The American College of Surgeons' influence in the United States was on a meteoric rise, and he was our chairman here for 9 years. It was taken away from us early from an MI, once again, something that had run in his family, but he had a dramatic effect on the training here over those course of the 9 years. So who was this man? He came from a physician's family, which is not uncommon back in the early 20th century. He came from Polish immigrants. They migrated here in the 1800s, and he was born in 1906 here in Shreveport and died in 1959. His father, Louis Abramson, graduated from Tulane in 1899. It's hard to think of anybody in the 1800s, but LSU Medical Center didn't start till 1934, and the Tulane Medical School started in 1834 as the Medical College of Louisiana. It started as a medical school and transferred to the state of Louisiana and then was taken over by private funding after that. But almost everyone in Shreveport during Dr. Abramson's vintage was a Tulane grad. There was no LSU grads. So when you see that, and you see that in the literature of Shreveport, and we're working on a publication, a book right now on the history of Shreveport surgeons, and also in North Louisiana. So Mr. Abramson, or Dr. Abramson, I should say, joined forces with T.E. Shumpert, who is the benefactor of the largest Catholic hospital that stood in the southeastern United States on Margaret Street, which is now St. Mary's, for quite some time. And in 1907, Louis Abramson, Dr. Abramson's dad, started North Louisiana Sanitarium, which morphed into Doctor's Hospital, and now is Willis Knight Rehab up on the hill that y'all passed by, that beautiful. It used to be Doctor's Hospital. This is the shot of North Louisiana Sanitarium back in the 30s, modern brick building. Everything was new. First-class table, and I'm not sure what that meant. Operating room table, whether it was the dining services, ambulance service, and all outside rooms. Nobody wanted to be hemmed in the middle of the building, so everyone had a window. And they had trained nurses, believe it or not. But I'll leave it at that. But Dr. Abramson himself was educated in Shreveport Public Schools. Byrd High School started in the 30s, late 20s, so he was educated here much earlier than Byrd High School even appeared. He went to LSU in Baton Rouge and finished in biochemistry, and finished at Tulane in 1927 at the chagrins of his dad. He wanted to go to Baton Rouge because it was a better party school. His dad knew that he had to get him out of the party environment and get him down to Tulane where he could really party or really study. We're not sure. But he went to medical school at Tulane in 1929 and interned at Charity Hospital at the very early stages, and there were no LSU residents at that time. He came back to Shreveport and joined his father at this institution and immediately began training surgeons at Shreveport Charity Hospital. Now, where was this geographically? This hospital was built in 1953, but the old medical surgical Shreveport Charity Hospital was on the corner of Murphy and Texas, whereas the police station stays, up on a hill. And if you notice, places were built up on hills for a reason, because mosquitoes were in the bases, mosquitoes were at Silver Lake at the bottom of Shreveport in the bottoms, and all the medical centers were as high as they could get them to stay away from the effects of the effects of mosquitoes and malaria and yellow fever. So that hospital had 800 beds with an occupancy rate of 97%. This hospital now has about 400 beds with 30 or 40% occupancy because of the quicker way of us getting patients in and out. And Dr. Abramson was a fellow of the American College of Surgeons in the 1930s. Our program didn't get recognized and approved by the American College till the 1940s under the care of some of the surgeons prior to Dr. Abramson. And in World War II, for 3 years, he shipped out of New Orleans and was in France at Tulane Surgical Field Hospital as a major, not unlike our speaker today. So Dr. Abramson committed himself to the American College, to Shreveport, to several things in Shreveport and several things in the United States and the region. He also, in 1931, urged people to buy seals. These seals were a way that you would pay and help with the delivery of tuberculosis medications, to fund sanitariums where patients convalesce with tuberculosis. And they were Easter seals, they had lung seals, they had all these little microcosms of things that you can donate to help the care of some of our patients. He examined babies. He was a surgeon, but he went and examined babies at the fair, at the Shreveport State Fair, which has been here for decades, if not 100 years. He went to speak at the YMCA. He would speak on the advance of physical exercise, physical fitness. So he was everywhere. He was truly someone who was revered in the city of Shreveport. He joined the Army once again at this young age, and all the doctors there were very few doctors left in Shreveport during World War II, especially from 1946 and around that period, and he shipped out and spent 3 years there. In this hospital, I looked up the hospital, the number of patients and combat victims that were seen in the thousands. This was not somewhere where you went, played cards. You was someplace where you go and you really learn the advance of vascular surgery and treat our wounded. He was a Shriner. You'll see in a picture in a few minutes. He was part of the Civil Defense, which was active during the Cold War. He was a Rotarian and had just a ton of influence in the state and also the city. He was president of the Louisiana State Medical Society, Shreveport Medical Society, and was president of the Louisiana State Chapter of the American College of Surgeons. And I really believe if he had continued and had not been taken away early, that he would have moved forward in the American College at a national level and with more influence. But he was our chairman here, not physically in this hospital, but on Murphy and Texas Street from 1951 to 1959. He had medical libraries in almost every hospital dedicated with his name because he was such a proprietor of education and publications, and he had roughly about 70 publications. Back then was a huge number for surgeons, especially locally. He had educational funds, which are still in progress. There was an award that preceded this lectureship for interns here at, it was called Shreveport Charity Hospital, now at LSU, for the Outstanding Surgical Interns Award. Dr. Dean Griffin got one of those awards. And Dr. Tommy Lally, if you're on YouTube, Tommy, congratulations, you got one of the first and early awards from Dr. Abramson. It's as him taking over the gavel at the Louisiana State Medical Society in New Orleans. Look at the dress, a little different. Those aren't white coats, those are tuxedos. And that's the standard fare at that time. This is him as a Shriner, and he actually took part in taking care of some of the crippled children's chest wall deformities over at Shriners, which is the longest standing Shriners in the United States. And he succumbed to a heart attack once again at the age of 53 at his home, and was taken aback. And all the surgeons in town and in the region collectively got together and donated a huge amount of money. It's a pittance now of what it used to be, and this was perpetuated year after year by surgeons who truly respected Dr. Abramson. First Abramson professor was actually not during Dr. McDonald. I was remiss to think that Dr. McDonald started this lectureship, but it was Dr. Frank Kurzweg who was the chair of surgery from 1968 to 1976 here at LSU in the latter part of this building. Dr. Kurzweg was from Plaquemines, Louisiana, trained at Charity like Dr. Sutherland, and went to the University of Miami where he came in contact with Dr. Dean Warren. And I'm not sure any of you know who Dr. Dean Warren is, the treatment of esophageal varices with the Dean shunt, the Warren shunt, or the spinal renal shunt was actually advocated by Dr. Dean Warren. He was the first Abramson lecturer in 1972. Dr. Donald Trunke was the Abramson lecturer when I graduated from this institution about 30 years ago. Dr. David Sabison was a 1976 Abramson lecturer, not long before Dr. McDonald started, as Dr. Kurzweg was changed over and Dr. McDonald took over here then. So we had some really grand names. These are the last 20 years of some of the, I think, real building blocks of American surgery that came here to Shreveport to be able to share their message with us. The more things change, the more they stay the same. This is Alton Oshner, who came to Shreveport, was talking to a Charity Hospital pathologist who was huge in medical education, Dr. W.R. Matthews, and it's funny now that we are aligned with that institution. And finally, Dr. John McDonald unveils this portrait, which now stands over by our lecture series hall in 1980 of Dr. Abramson. And Dr. McDonald was big in surgical history. He believed in perpetuating the people and standing on the shoulders of some of the giants that started the program here. And this is Dr. McDonald, of course, many of our mentors in 1980 who unveiled the portrait of Dr. Abramson. So without further ado, I'm going to introduce our speaker today, who's really a friend of mine and has helped us in every way possible here in Shreveport in moving forward with recertification, re-verification of our trauma center. He grew up in Baton Rouge. He was an Eagle Scout there, went to Catholic high school, and we talked last night over cocktails about Catholic high school and some of the people he still keeps in contact with. He was an LSU undergrad degree in microbiology and went to medical school at LSU New Orleans and entered the United States Air Force, where he received his general surgery, thoracic, and vascular training, and remained with them for the next decade and served as surgeon at Keesler and also at Travis Air Force Base. He was the chief of thoracic surgery and staff trauma surgeon at the 332nd Division at the Air Force Theater Hospital in Iraq and received 10 military awards and decorations. And he has held academic appointments at UC Davis, University of Arkansas, and is currently a professor of surgery at The Ohio State University and clinical faculty at Northwestern University in Chicago. He also got his MBA from Ohio State. Dr. Sutherland has held major leadership positions in the American College of Surgeons, especially in trauma surgery, program development, systems management, and also educating young surgeons. He is currently director of the member services at the American College of Surgeons and has traveled extensively and speaks extensively and is an excellent orator. He served as state trauma medical director at Louisiana Emergency Response Network for the last 6 years. It's where our paths have crossed. And this man knows trauma and trauma systems backwards and forwards, and he's assisted us in this institution in every way possible. So Mike, come deliver your message. Thank you for coming, and we appreciate it. Pull yours up here. That's fine. I got it, my friend. There we go.
Can everybody hear me? Great. So it's an honor and a pleasure to be here. I'm not sure why that's. There we go. So it is an honor and a pleasure to be here. I really don't like standing behind podiums that much, so I'm going to walk around a little bit. I appreciate the invitation, and the time that I've spent here so far has been fantastic, and I look forward to the rest of the day today. I wanted to share with you a little bit about organized medicine, and it's something we talk about, something many of us are members of, but it's something that's really kind of important and is becoming more important even as generationally we see people less interested in it. And my hope today is to share with you a little bit about what's involved. I may be stuck behind the podium. So what's involved in organized medicine, and there we go. So why am I talking about this? Is we're going to cover that a little bit, go through what surgical organizations are, look at activities that benefit the members of these organizations, and then really kind of try to tie that together with how the American College of Surgeons fits that definition and delivers for the members of the organization, things that you just can't do on your own and are really going to be problematic for us as a profession if we leave them unaddressed. And then ultimately, this has to be a value equation. How do you derive value from membership in these organizations? And my hope is that by the end of my talk, that you'll see that there's something that's out there for everyone involved in these types of organizations, and that we can deliver value year after year and really engage with individuals and engage with the profession in order to heal all with skill and trust, which is our motto at the American College of Surgeons. We're back up and running. So really, what does it boil down to? I've got a few disclosures. As Dr. White pointed out, I've been involved in multiple medical societies. I work for the American College of Surgeons. So I'm kind of a true believer. So that's going to skew my presentation to you. And there's people that have alternate thoughts about this, and I welcome that discussion because I think that we can really kind of get into some of those details about what makes a good organization, what makes a valuable organization. And my ultimate goal here is to present to you a cogent, logical argument that really demonstrates there are benefits out there, and it's important for that continued participation. It really boils down to these being groups of people that are united around a common theme, that are there to promote the profession that they belong to, setting standards, advocating for the profession, and then providing resources to members in order to make them successful. my background crosses a lot of different spectrums. Dr. White touched on some of those, but between my time at the military and the VA, I spent time in private practice. I've had multiple academic appointments. I currently, work in an academic medical center. These all shape a set of different perspectives that people bring to how we deliver medicine. And if you work in one of these areas, then you know it really well. And if you don't work in or have never worked in one of these areas, it can be very different than what you're used to. So when we look at these surgical organizations, like the American College of Surgeons or any of the other organizations you may belong to, our goal is really to kind of cross that entire spectrum that people participate in and ensure that we're offering information and products and services that are meaningful to those individuals. So there's some common factors that surround these. They're usually non-for-profit. They serve multiple members of a common field, but they start to differ a little bit. Professional organizations are the same thing as professional societies, and they're usually made up of members of the profession. So you and me would belong to a professional organization or a society, whereas a trade organization, which is the other end of the spectrum, is really about representing the interests of the entire trade, and it's usually made up of employers or companies of a specific industry. And I think that to do that, you really kind of need to know what the goals are, to understand kind of how this fits together. You're really out there lobbying, you're out there actively engaging to promote the economic activities of the organization, of the profession, or of your trade. Ultimately, this becomes, at some point, you've got all these things that we're going to talk about today that these organizations do, but ultimately you're trying to protect what your profession does from encroachment, devaluation, or people doing things that undermine the good work that we do as surgeons. We want to maintain ethical principles and really expand the knowledge set and provide a framework for the change of medicine to occur in a structured environment where the education leads to enhancements of care rather than experimentation and poor quality adventures into new learning or new areas of surgical knowledge. So I split this up, and the largest U.S. professional associations, these are the groups that have members just like you and I, and you'll recognize some things on here. The National Association of Realtors is the largest in the country. That's not a big surprise, there's a lot of realtors. But the next largest is the American Bar Association. That's a group that we sometimes find ourselves on the opposite side of the table with, right? CPAs, the AMA, radiology technicians, et cetera. The American College of Surgeons has about 90,000 members. Then you look at trade organizations, and that group is highlighted here by the American Hospital Association with 55,000 members. Another group that we sometimes find ourselves at odds with when it comes down to allocating resources and how we interact with our legislature and our legislators. So all of these things in common are competing for their piece of what's going on. They're trying to support their group, they're trying to support their constituency, if you will, and provide them with good public relations. I mean, everybody knows what the realtor sign looks like, right? You get the big R, everybody's seen that. They've gotten that message out. The Bar Association, everybody's heard of them, but nobody wants to have an involuntary interaction with them. But you all know that they're out there and that they're a representative group that's representing lawyers. The Hospital Association, same type of thing. So that all these cross that. Collecting and publishing statistics, many of these organizations, amass the knowledge of their members to be able to provide data, to show what's going on in the industry, to show what's going on locally, and provide a reference point so that they can then advise their members on new technologies, management issues. They promote research, sponsor conferences. All of these groups have annual conferences, including the American College of Surgeons, October, Boston, should be there. It's going to be a great meeting. And then monitoring regulations in the field. So there's a whole aspect of this that revolves around what happens in Congress, and we're going to talk about advocacy in a minute, but just as a preview of that, there are, the old adage is that if you're not at the table for the discussion, then you're on the menu. So there's a fixed amount of money that's being divvied out in Washington in terms of payment for Medicare, Medicaid, hospitals, et cetera, and that it's a fixed amount of money. So if somebody's getting more, then everybody else is getting less. And part of the role of these organizations, whether it's the realtors that are working on regulations and working on housing and Fannie Mae and Freddie Mac and those types of things, or if it's the surgeons dealing with the Department of Health and Human Services, people are out there having conversations that if your organization isn't representing what's best for you and our patients, then you're going to wind up on the losing end of that stick. And we can talk a little bit more about that later. And that really boils down to what this lobbying aspect of these organizations is about. It's to protect the members from adverse events that are generated by legal or legislative or regulatory programs in the states or in the capital that would impact that organization's ability to be effective. And then, as I mentioned, many of these produce a newsletter or a magazine or something along those lines. You probably, if any of you have had the misfortune of hitting 50, you've probably gotten an invitation to join AARP, and I don't consider myself anywhere near retirement, but they send you a newsletter and they send you an introductory offer with a magazine, so you can learn more about what they do for those people. So it's common across all of those types of organizations. But just a simple Google search, if I put in physician professional organizations, this pops up at the bottom of the screen, and your reputation is huge in this space. So the larger your organization is, the number of members you have, and the reputation that you bring to the table are enormous in the effectiveness of your organization representing what you do and providing the resources that you need. And you can see that on this, I didn't plan this, I just found it. It was actually serendipitous that the American College of Surgeons pops up as one of the largest medical associations, and I would argue one of the most effective. There's 4 different types of things that medical organizations typically do, especially surgical organizations. There's designation and granting of designation granting associations. So the American College of Surgeons does that, as do many others. They set forth a group of standards. They then put that out there, and they say that you've met those standards. They then certify that you've met those standards. Another example is American Board of Surgery, who many of you are either attempting to get a certificate from or have a certificate from, which certifies individuals as having met those standards. So that's a professional organization with a little bit of a different focus. Professional regulatory bodies, think something like the Joint Commission that's out there that is looking to regulate what is occurring in the delivery of health care. And then finally, these member benefit organizations that really are the professional associations that bring opportunities to the member, whether it's education or any of the other 10 items that we're going to talk about in the next couple of slides. So you don't have to be purely one of these. They can go back and forth across different aspects, and they can have different branches of those organizations that provide this. But you can see where all of these types of engagements and these types of interactions that are provided by those organizations can potentially bring value. So there's literature out there to support this. This is out of Forbes, and it talks about how it can amplify your business. So if not necessarily surgical related, but certainly there is some cachet. People in communities want to have FACS behind their name, or they want to have partnerships with their organizations representing the quality that they do to their that they offer to their patients. And then you can see even in JAMA as far back as 1995, there's clearly a recognition that academic physician participation in organized medicine brings value. And this article goes on to talk about how this participation is seen as a positive impact for both the physician and the care that's provided in their communities. So what I thought we would do is kind of go through these top 10 items that the Joining Professional Society offers. And I'm going to try to take these one at a time and discuss with you briefly how that applies to you as a surgeon and how the American College of Surgeons represents that for you. So from an educational standpoint, I think everybody recognizes that the American College of Surgeons offers a broad array of educational offerings. One of the things that across all 10 of those items that I showed you, in what I hope to show you in these subsequent slides, is that while you may think you know some of the stuff that we offer, I'm almost certain that everyone's going to walk out of here with, I didn't know they did that moment. Because I still have those and I work there every day. And a week doesn't go, it used to be a day doesn't go by. I'm a little bit better now. A week doesn't go by where I don't go, I didn't know we did that. And somebody's like, yeah, we've been doing it for years. I'm like, well, it's the best kept secret in the world. So, from an education standpoint, if you're a resident, surgery fellow, and medical student, this is just a sampling of some of the programs that the college offers. Everything from assessment of readiness for residents entering their training program. This is a cognitive assessment that's designed to test not medical knowledge, not skills, but judgment and maturity to know where you sit and offer opportunities and offer assessment results that will help you shape areas that you can improve in. We've got InSize, the medical student simulation-based surgical curriculum. You've got the surgery resident skills curriculum. SCORE is a function of the American College of Surgeons in conjunction with the board and many others. I'm sorry, there's another fundamentals of surgery curriculum that is important. And then APDS, the Association of Program Directors in Surgery, partners with the American College of Surgeons on the surgery resident skills curriculum. The physicians in the audience that are already board certified out of your training will be familiar with CSAP. This is on its 18th edition. This is released every 2 years and is an incredible resource for studying for your boards and then studying for research if you're still on a 10-year certificate. There's audio companions, supplemental selected readings in general surgery is a common tool that's used in residency programs for maintenance of up-to-date understanding of what's coming out in the literature, where the best articles are abstracted and presented to you. This specific chapter is on the spleen, and over a 5-year period, you go through the entirety of a general surgery curriculum with this, and it's administered by Dr. Lou Flint, who's medical director for that program. Tulane chairman of surgery in the 80s and into the 90s, and does an amazing job with that. Optimal Resources for Surgical Education and Training, the so-called Gold Book. I bet you've got a copy of that in your office, and it's really one of the things that helps define the best ways forward, what's necessary to be successful in an education program for residents. Clinical Congress, I mentioned earlier, October 22nd through the 26th in Boston, is another great opportunity for that ongoing learning and education that's out there. Surgical organizations should be offering job prospects or helping you with job prospects. And there's some new stuff in here that's really kind of interesting that I want to share with you. This is the ACS job board. This is one of those that I didn't know we had. So for those of you that are looking for jobs in the upcoming years, this is a great resource. You type in the keyword surgical oncology, you type in breast surgery, you type in trauma, whatever you want to type in. You click your location, click search for jobs, and it pops up with a whole list that you can sort through people that are actively posted jobs. You can post your own CV to this and have it circulated among other groups. And we're working on an addendum to this that I'm probably going to sign next week that's going to allow you to anonymously tell the system what you're looking for. I want a job in this geographic area, whatever that is, that makes this range of money, that takes call in this frequency, that has no trauma, sorry, that has endoscopy and, whatever you want to put in there. And it anonymously uses our job board and all the other job boards out there to search and find those jobs with that degree of specificity such that you only get notified when something meets your criteria. So the wider your criteria, the more notifications. But, Dr. White was moved back here to Shreveport. He could have put in 5 years ago that he wants a job that's just in Shreveport because he wants to move back closer to quote-unquote home, and it needs to be a department administrator job, or it needs to be an academic position, and you can put that stuff in. So we think that that's going to be a really impressive addition to the job board. We have resources on the website for CV review through the job board, where you can send out your CV, and this group looks at it. It's a free service, helps you update your CV such that it's in the best possible shape to represent what you are and who you are for your career planning. And then this is just another snippet off of that same website. And you can see here that there's 2,500 employers with over 1,100 jobs, and that changes day to day on a regular basis. We've also added some resources that I think are huge, especially for those of you that are going out into practice over the next few years. Everybody that, and please correct me if I'm wrong, but everybody tells you it's important to have an attorney look at your contract. Have you heard that? Where do you find the attorney? Right? So Jim Bob that processed your title transfer when you sold your '78 Ford pickup truck is probably not the person you want reviewing your contract. So we partnered with a company called Resolve right here, and that's all they do across all 50 states. They look at contracts for physicians. They give a discount to the American College of Surgeons members, and the whole idea is that you get a year of data subscription. This is just one of the packages that they have. You get MGMA data. You get one contract that they'll review. They'll do another package that has 3 contracts. They'll get on the phone with you. They'll make red line recommendations. They'll do full benefits review to make sure it's competitive. And then they have 90 days of attorney access by phone and email. And they'll even get on the phone with you while you're talking to your future employer to say, we think that this is, could be better in these areas, and help you negotiate that. You're like, I want the do-it-yourself model. MGMA data, AMGA data, and if you're going into academics, AAMC data reports are available from the college now at substantially discounted rates. Normally, if you wanted MGMA data, you'd pay $2,000 for the set of the whole book. This comes to you as a college benefit at under it's like right at $500. So it takes it for something you got to really, really think about to something you just have to kind of think about, especially when you're trying to negotiate a deal. This is a negotiation seminar that we did last year at the Leadership and Advocacy Conference. It's on the website. You can take full advantage of it. We brought in somebody from one of the best business schools in the country at Georgetown. I think she's from Georgetown. And gave a 2-hour talk on negotiation tips and tricks and things that you need to know to be successful in negotiations. And it doesn't really focus on medicine. It's really talking about how do you negotiate everything from buying a house, buying a car, who's going to do the dishes, whatever you want to look at from a negotiation standpoint. It's really a fascinating talk, and I encourage you to take a look at it. The college also has mentoring programs, because that's another feature that's important from a surgical society program. And we break that out over different areas, and it kind of has a little bit of a different look. The ACS Outstanding Mentor of the Year Award is an award that's given to recognize mentoring, especially in out in the community, out in the country. We have a YFA annual mentor program where there's direct matching, and we have the Committee on professional opportunities for senior surgeons. So if this is the RAS, and that's the Young Fellows Association, this is the Old Fellows Association, but they didn't like that title. They have a program where they do mentoring as well with mid-career surgeons to help identify ways to match people up and work through either limited or long-term mentoring engagements. The COT, Committee on Trauma, has a mentoring program for early career surgeons, and it's really a big piece of what we're trying to develop is an opportunity for that direct engagement to support the members of the college. We talked about advocacy earlier. This is really a huge aspect of what any professional organization is doing. And if you really want to distill this down, this isn't where we started. You know, we started as an educational and a standards organization back in 1913 because people were doing crazy stuff and there was no regulation of surgery. The Joint Commission is a direct descendant or offshoot of the American College of Surgeons to help hospitals identify processes and requirements that were necessary in order to be safe deliverers of health care. That went off and has done its own thing, and it's still part of the legacy of quality from the college. And education, we've talked about how important that is and what the college has done from an educational standpoint. 20 years ago, we restructured the American College of Surgeons into an organization that can participate in advocacy because it became readily apparent that if you're not at the table, you're on the menu. And if you don't have the right structure and you don't have an emphasis on this advocacy piece, then people are going to be doing things that are not in the best interest of the surgeon, and more importantly, they're not in the best interest of your patient. So how do we get that in front of people? How do we get our surgeons in front of people and share that message? We are the experts. We know what the patients need, what's important for the medical profession, and we really kind of see those changing trends and can bring credibility as professionals to the discussion. The legislators want to hear from you. They want to hear stories about your patients. They want to know where the friction points are because that's really the only way they're going to make an intervention. So what's important in this? Well, strength is in numbers. So when you represent 90,000 surgeons, it's a big deal. If you represent 150,000 surgeons, it's even a bigger deal. So we want to be that umbrella for all surgical specialties to go in and talk about things that are affecting access to care and affecting our ability to deliver the best possible care. Participation by the members is huge, and it doesn't require like a lot of effort. You know, you can pick up the phone and talk to your congressman's office and say, hey, I want you to know that I don't favor this. This is bad for our patients. This is bad for, this legislation is bad, or somebody needs to, he needs to or she needs to vote for this bill because it's important for us to be able to deliver care in the underserved area of northern Louisiana. Grassroots activities, that's what we're talking about. We're talking about individuals stepping up and doing things, and I'm going to show you how we've made that really easy. Educational activity, this is an educational activity. There are 23, it changes, so I think it's 23 right now, physicians in the U.S. Congress. That's it. So everybody else is a business person, a lawyer, or something else that has landed them in a decision where they're making votes and they're making decisions on what affects your patients and what affects you as an individual. So we have to educate those individuals so they understand the circumstances, the downfalls, the things that pass through to the patient as a result of the decisions they make. So really, we look at this whole advocacy thing as an educational exercise rather than an arm twisting or anything like that. And then it's also important that we encourage others. There's two different ways that congressional accountability can be achieved. So I mentioned earlier, right, wrong, or indifferent. If you're not at the table, you're on the menu. And if you don't like it, you don't have to, but it's the reality, right? So there was a big pushback 20 years ago when we started doing this. Surgeons don't advocate, we take care of patients. This is dirty politics. We don't want any part of this. The problem is that there's a bunch of other people that are out there engaged in this activity, and if you don't want to be heard, then you're going to wind up on the losing end. So we also realized that surgeons are also very busy people. So we created Surgeon's Voice, surgeonsvoice.org. You click the button, it brings up a list of the issues that are out there. You figure out which ones make sense to you. You may get an email from the college saying you need to act now. Click here, it takes you, and in 3 clicks, you can send a letter to both of your senators and your congressman. 3 clicks. It doesn't take 5 minutes to do the whole thing. So I don't care how busy you are. We've got this set up to where it works off your cell phone, and when you're walking from the OR to talk to the patient's family, you can do this. It's just that simple. And then this really is, because you're a constituent. Whether you voted for them or not, you're a constituent to that individual. And what's the number one priority of any politician? To get reelected. That's the only thing that's on their mind, is to get reelected. Okay, everything else is secondary. So they want to hear from you, and they want you to communicate with them. Now, the similar thing is that how do you get reelected? You have to have money. So they care about people that are constituents and people that are supporters. So the Surgeons PAC is a big feature of what we do at the college. It's a very simple, again, surgeonspac.org, very simple to go in and start a habit of engaging in that way. Your professional politics have to be somewhat separate from your personal politics sometimes. So I hold my nose at some of the people that we give money to every year, but if they're the chairman of the Ways and Means Committee or the ranking member of the Ways and Means Committee, we kind of have to be in a situation where we have a dialogue with that individual. We want to be able to pick up the phone and have them say, sure, we'll make some time tomorrow for you guys to come in and talk to us and educate us on the issue that you see. And this is the kind of access that the participation in the PAC provides. So many of us in the room have been around and seen new technology and new procedures come about. We heard about it this morning where there are several new procedures and new technologies that were instrumental to the successful management of patients that were presented. How does that get promulgated? How do we get that out to people? How do we ensure that skills acquisition and training is right? How do we make sure that skills acquisition after training is right? If you think back to early 1980s, there was no such thing as a lap chole. Everybody got a subcostal incision, and I would be willing to bet that the vast majority of you have done less than 5 of those as residents, unless you were doing it as part of a big open laparotomy. It just doesn't happen anymore, and that's a good thing, right? Because they go home faster. My wife had a cholecystectomy on a Wednesday and was out shopping for something for the kids on Thursday. You know, it's really revolutionized what used to be a 6-week convalescence into almost a non-existent issue. But how do we do that safely, and how do we get that information out? There's opportunities for all of these panels discussions in controversial topics in surgery. That's interesting. We got a slide out of order. This is the Surgeon's Voice, where you click here, write a letter, 2 more clicks and you're done. And then this is the PAC one, so sorry about that. But yeah, so panel discussions at Clinical Congress talking about the controversial topics. When's the right time to offer somebody a colon resection for uncomplicated diverticulitis? Or, you know, and that changes over time. And how do we have those conversations and share that information? So that's about that new procedures and the new technology and the evolving technology and how we get that out to our members. Surgical organizations should also provide access to resources that you can't necessarily get somewhere else, or they're so expensive that it's prohibitive for an individual to buy them, so the organization provides that. Or prohibitive for the individual to develop it. Practice management tools, we talked a little bit about some of those earlier. I'm going to show you a couple more. Patient education materials, and then publications and different types of podcasts that the college produces to make sure that everybody's aware as much as possible about what's out there. Patient education, there's a whole website, ACS for patients, preparing for your surgery, how to recover well, home skills. We've got video seminars that go through the entire education of colostomies and ileostomies. and even have home skills programs for those types of things that come with devices that you can put in your hand, follow along with, and they're very popular and they're extremely well received. We also have some general patient education material that's out there that some people subscribe to. It's similar to what you find in your EMR, so it's not for everybody, but it's got really good stuff that you can access readily. I told you we do some publications. The ACS brief comes out every Tuesday afternoon at around 4 o'clock. It's the summary of what's happening in the college and what's happening across the country, things that you need to know about. The bulletin happens once a month. This used to be something that you got in the mail with your copy of JAX. It's transitioned now to an online presence, and it's interactive. There's videos, there's a lot more pictures in it. It looks very different, and it is very different than what it was even just a year ago. For decades, for as long as I've been in the college, the running joke is, how do you hide something from the membership? And it's, you put it in the bulletin. I want to see us change that to where people are actually taking an active part of looking at what's in the bulletin, because there's some really great articles that talk about great things that people are doing as surgeons and great things that are happening for the benefit of our patients as well. JAX, the Journal of the American College of Surgeons, is a great resource. Publications, many of you have probably submitted to JAX over the course of time, but this also has transformed, and it's largely an online platform, giving us the ability to do video presentations, to have color in it without the added cost. You know, when I was a resident, you wanted to present something that had color in it, they charged you money to have 2 different colors on the slide. And if you had full color, it was prohibitive. Nowadays, that's really not the case, and you can actually find some really amazing stuff in there. For those of you that are in not in a time-limited certificate from the board and still have to do maintenance of certification with, drawing a blank, it's the self-assessment CME. Every single issue of this has multiple hours of self-assessment CME, and I find that this would be one of the best ways to do it, because I can have the one window open with the questions and one window open with the article, and we can figure that out, right? So it goes pretty quick, and it's great. We're on Twitter, we're on Facebook, we're on LinkedIn, and other social media, and that's something that evolves on a regular basis. If you're not subscribed, I encourage you to do so. It's not overly burdensome how much stuff goes out, but some of the stuff's really interesting, and it helps know what's happening in the world. And for those of you that like podcasts, there's 3 of them. The Operative Word, which is got CME associated with it, surgical readings from selected readings in general surgery, and then the House of Surgery, which is more of a history and multiple specialty discussions and things about how there's interactions across the different specialties of surgery. So professional development, we're back on track. There they are. So the professional development piece that we talked about earlier, and I told you, so we've got exported ultrasound courses. The college logo's right here on fundamentals of laparoscopic surgery. Most of you should have, if you don't, or you will have, one of those pens that say that you've passed this hurdle in your education. That's a college program in conjunction with SAGES. The accredited educational institutes are another piece that go along with the gold book that talk about how well you're delivering that care. And then medical student simulation, we talked about that earlier as well. So there's just so much stuff that's out there in terms of how do we prepare people for delivering care in a changing environment. These are some of the topics that are on the skills courses at the Clinical Congress this year. How do we get new technology and new ways of taking care of patients in front of people? And it's part of this educational pathway. You know, CESTI, which is the Committee on Emerging Surgical Technologies and Education. We got a whole committee that's focused on how to deal with new technology. And where did that come from? It came from right here. How do we get our hands wrapped around ultrasound as surgeons back in the early 1990s when surgeons didn't do ultrasound? An ultrasound machine was the size of that podium, and it lived in radiology, and the radiologist would stand in front of it and guard it with their life that you can't go anywhere near it. So we had to come up with some innovative ways of doing that. But these are all different ways that you can be involved and learn new products, new processes, and this changes every year because what's new this year is not necessarily what's going to be new next year. So, I talked, one of the other items on that list was increasing individual visibility. Why is that important? Well, if you want to make a name for yourself in the world of surgery, you're going to have to be in a position where you're presenting and you're out there being seen and engaging with people to share your knowledge in a way that resonates and helps them understand what's important to you and learn from it. We offer the opportunity for presentations at meetings, and whether that's the surgical forum or whether that's a clinical congress on the podium as a moderator or as a presenter, participations in committees. So we've got tons of committees in the, and this is just an example. Each one of these has multiple people presenting. There's multiple individuals that participate in this, as well as every other one of the over 200 activities that happen at Clinical Congress, and that's just one of our meetings. Participation in committees, the Advisory Council for General Surgery. I think everybody in this room can recognize that that's a group that you could identify with. There's names up here that you're going to know. So there's Tim Everline, who's the chair of the Board of Regents, who's at the Washington University, St. Louis. And then you've got John Stewart, who's down in New Orleans, who's the chair of not only the General Surgery Advisory Council, but he's also the chair of all the chairs of the advisory councils. And some of these other names, Dan Dent and Carlos Brown and Ken Janaba, all these people may ring a bell with you. These two don't, I bet. Kyle Vincent's a young fellow under the age of 45 who is spending time multiple times a year in a committee with all these huge names. And Douglas Gauch is a medical student. I'm sorry, not a medical student, a resident in the same situation. There's opportunities. Now, when these people go to look for a new job, look at all these people that they've interacted with who now know them personally, and they've increased their individual awareness. There's opportunities like that throughout the college. The Resident and Associate Society is a huge success in the college. Every resident in here should be a member. I'm going to get to that in a minute at the end, talking about the value equation. But every resident is eligible to participate in the college. And it's not just general surgery residents, it's pediatric surgery residents, it's colorectal residents or fellows, it's orthopedics and OBGYN, ENT, ophthalmology, urology, etc. And the idea here is it's a way for you to participate, be engaged, meet other people, develop lifelong friendships, develop engagement with senior members of the college that are going to serve you well into your future. Young Fellows Association is the next step beyond that. After you finish your residency, you put FACS behind your name, you're now in this Young Fellows Association, which is really focused on developing the practice-specific issues of young surgeons as they're entering the surgical workforce. How do I enhance what I know about practice management? You know, YFA said, we need more information about this, so then the college builds some of the stuff that I showed you earlier. So these are two really huge, very easy to participate, very easy to get involved. They're open to anybody that wants to be involved. And the nice part is you can start out being on a committee where you do some conference calls, work your way up to where the college is paying you to come to the American College of Surgeons meeting, paying for your hotel, paying for your airfare, and you're also interacting with all these people, and it's got lifelong positive repercussions. I told you earlier that the college was founded on the concept of quality, and that really hasn't changed. It's the core of what we do at the American College of Surgeons. It's also the core of what we want to be doing as surgeons. I don't think anybody in here would argue with me that quality isn't important to them. So how do we work with that? We need to set quality standards across specialties. Somebody has to be out there saying, what does quality look like? How do we measure quality? What are some of the programs that are available for us to look at quality? This is something you may not have seen yet. This is called the Quality Diamond. It's a surgical quality partner program that individual hospitals that get evaluated, just like a trauma survey, as meeting the standards of the optimal resources for surgical quality and safety, are awarded this no different than, say, a JACO acknowledgement or something like that. Then if you think about this and you put, oops, go back. If you put right here a trauma diamond, and you put right here a cancer diamond, you put right here a bariatrics diamond, you put right here a pediatrics diamond, it's a way to demonstrate a hospital's commitment to quality in a visible way that winds up in your front lobby and turns out to be a driving force for patients to your facility. And we did some survey, we did some analytics on this, and the reality is if you survey a group of people that are not physicians, that are not healthcare providers, and you ask them, are you more impressed with the American College of Surgeons quality diamond or the U.S. News and World Report's ranking of your hospital, 80% went with a surgical organization as preferentially assessing what quality is in a hospital as opposed to a defunct magazine. It's true. These are some examples of how you might see this. These are just some different places that this type of stuff could present, but ultimately it really is about defining those quality measures. We have a conference that happens actually in about 2 weeks, 3 weeks in July. It's in Minneapolis this year. This used to be the NSQIP conference. I talked about different programs, overarching programs, NSQIP, TQIP, the bariatric program, the pediatric NSQIP. All those programs are really brought together at this quality and safety conference, and it's designed to share best practices. There's a huge poster session where hospitals across the country bring their best outcomes, their best performance improvement programs, and share those with the participants. They also have quite a few panel sessions and workshops on how do I get started and how do I go to the next level and what's the basic, the intermediate, and the advanced version of this. And then we talked briefly earlier about the optimal resources for surgical education. Because it really is this pathway. How do we engage with the surgeon, the hospital, and then subsequently the system of care that that organization offers in order to assure that we have the proper certification and accreditations that are recognizable across the country and demonstrate the quality that's been independently verified. I talked about these programs. We have optimal resource guides for all of these. Vascular is brand new. Emergency general surgery is brand new. And we've got general thoracic surgery and high-risk gastrointestinal surgery coming in the near future. But this is an attempt by working with our advisory councils for thoracic surgery, for vascular surgery, for colorectal surgery, for pediatric surgery, the Commission on Cancer, and our bariatrics groups to define what those optimal resources are and help facilities employ those in a way that's going to lead to a structure that results in improved outcomes. Trauma programs are a big piece of this. It's near and dear to my heart. You all heard that I'm a trauma surgeon by training. This is the new version of the Optimal Resources Guide for Trauma. ATLS, everybody in here has probably taken that at least once in their career. We just redid the national guideline for field triage of the injured patient. That hadn't been updated in probably about 15 years, and they brought together all the stakeholders. This has got national backing, and it's been sent out and is employed here in the state of Louisiana as an update to our trauma protocols, as well as across the country. And then there's current efforts on defining what a national trauma system looks like, and working with the federal government, Department of Health and Human Services, the different stakeholders across the country in the pre-hospital, hospital, and post-acute care world to figure out how to implement a trauma system across the country that can deal with contingencies, natural disasters, and anything along that spectrum. Lots of different pieces. This is the quality standards piece that's abstracted from the red book that I showed you earlier that leads to the quality diamond. We've got 700, it ties into NSQIP, where we have over 700 sites. 20% of those are international. Millions of patient records, 100 statistically risk-adjusted models that define what NSQIP looks at and what it looks like. And we've generated these best practice guidelines and case studies to help hospitals employ that. Cancer is a huge piece of this. Operative Standards for Cancer Surgery, Volume 1 and 2. That's another new product of the college. Volume 3 is in development. It's going to address adrenal, bladder, hepatobiliary. This stuff's moving on a pretty fast pace. So the question is, you know, what is that going to look like? Does this transition from being a book that you have to your e-book that is updated more frequently? And then cancer programs and what those protocols look like. We talked about cutaneous melanoma earlier today, thyroid, pancreas, and these are ideas about what protocols should look like and how you can implement those into your program from the Cancer Surgery Standards program. And we're kind of getting toward the end of the things that we do. But one of the most important things I think we do is offer networking. It's important to have shared experiences. Everything that we're talking about, everything we talked about this morning isn't unique to Shreveport, isn't unique to northern Louisiana, and it's not unique to general surgery. So how do we engage with individuals and create opportunities for peer support, for shared experiences, requests for advice and support, and working together to improve the care of our patients? And this is one of those that we put in this year, and you probably don't know about this because it was is for rural surgeons. The rural surgery community was engaged with this first. We're rolling this out here probably in August for all general surgeons across the country. But that's the old surgeon group that I told you about, CPOS, started this and said, you know, we can provide some opportunity for someone to connect and say, I got a question about fill in the blank. I've gotten sued, what do I need to do? I have this bad patient that I need some advice on. I'm having problems with my hospital medical staff. I'm looking for some advice. It's a one-off confidential discussion. You put in on the website your name and how you want to be contacted and the general concept of what you want to talk about. I want to talk about legal issues. I want to talk about medical staff issues. I want to talk about patient care, et cetera. And then we pair you up with somebody that has experience, and you guys have a phone call that we're not privy to, that no one's privy to, and it just helps get a better understanding of what's out there. It's part of that peer support group stuff that we're doing. The ACS communities, who's logged on to the communities? Yeah, not a lot. The communities are interesting, right? So I would encourage those of you that are general surgeons to at least sign up, go on the website and sign up for the general surgery community. And the reason I say that is that we've extracted all the extraneous stuff. So the general surgery community is very heavily monitored to make sure that it's just about clinical stuff. And in that clinical discussions, people will present cases, no different than we presented here, but they don't have the resolution. They're looking for advice, they're looking for an answer. And it's a really great way to kind of see what other people are struggling with and then hear what experts or other people that are actively practicing in the United States have to say about it. And there'll get to be some debate, and it becomes quite interesting. So it's a very simple read. It comes to you once a day at about midnight, so sometime during the day you kind of thumb through it. If there's anything interesting, great. If not, you swipe left and you're done. American College of Surgeons Clinical Congress, huge event, huge opportunity for networking. We talked about networking and engaging with people. This is the end of Clinical Congress. This year we've compressed Clinical Congress, and we're going to continue to do this to where there's no longer a Thursday component. You come, opening ceremonies are on Monday morning, and then we are done, and we have Taste of the City on Wednesday afternoon, and then the whole thing breaks down and everybody goes home. So it's shortening it. We're compressing the same amount of information into a smaller period of time. We're going to continue to offer asynchronous video presentations so that you can see what's happening, even if you don't attend. And it also increases the amount of CME that you can get. So in the past, you were limited to how many CMEs you could physically go to. Right now, there's over 217 CME for next year that are available to you after they're presented, because you can go back and watch them, and then you can go back and rewatch them, and you can still claim the CME. So really pretty interesting from that standpoint. And then the one other thing that I wanted to touch base on this engagement piece is our wellness stuff. So wellness and well-being have been a big piece of what we do at the college, and we didn't really call it that before. It was really kind of trying to help what standards were to make sure that people had access to what they needed and that the system was working to their advantage. And then we started seeing burnout, and we started seeing more and more burnout, and COVID didn't help that at all. So we've actually got a coalition of 80 different specialty societies and subspecialty societies that have come together to share best practices under the college leadership to identify structural, programmatic changes that can be implemented to help with wellness. Things that shift this from being a, you need to be more resilient, or you need to go exercise more, or you need to, that doesn't fix the problem that the system is rigged against you. So how do we create best practices to help hospitals provide the support that's necessary for the physicians so that those pressures aren't as extreme? And we're expecting that to be a huge piece of what rolls out over the next couple of years. And I said I was going to wrap this up with the concept of value. And value is quite simply the quality over cost. And I hope that I've been able to demonstrate to you that we, at the American College of Surgeons, provide a great deal of quality programs. We have something that hits most everybody in every stage of your career. And the cost piece becomes an important aspect of that. So I mentioned earlier that every one of the residents should be a member. It's free. So when you put a zero in the denominator, it really drives up the value. So if you're not a member, please see me afterwards. I'll give you my card. I'll show you how to do it. It's free. Your residency program can renew the entire group every year for free. And we just extended that from a 3-year pilot to an 8-year program. So nobody in this room that's a resident should ever pay resident dues at the American College of Surgeons, even if you do a fellowship. And that's something we think is important, because the only way to really see the quality is to be able to see it. And the only way you're going to see it is if you're a member. So it's important. It's important to reach out to your other specialty friends, the people that are working with you from neurosurgery, ENT, urology, et cetera, and share with them some of the stuff that you see that's a positive aspect of what the college brings to the table. There's many additional offerings that I did not cover today, because I can talk all day about what we do at the college, but there is something for everybody. And whether it's helping negotiate your contract, understanding what your benchmarks are, providing you with resources to help develop your quality program at your hospital, or just being there when you need some support, there's something there for everybody. And the activities that we offer are there to support everyone across the House of Surgery, because together we're stronger. That's the AMA slogan, but I'm going to borrow it. And ultimately, our goal is to heal all, everyone, inclusiveness, with skill largely benefited from our educational programs, and trust based on the quality programs and the things that we offer that are designed to improve care delivery across the entire spectrum of surgical care in the United States. I really appreciate the opportunity to talk with you today. I hope I've been able to deliver on what I said I was going to do, which is make an argument that there's things that you don't know about what we do at the American College of Surgeons that will benefit you. I'll be hanging around here afterwards. I'm happy to share with you my card. This is my contact information. If you want to take a picture of it, that's my cell phone number. You can call me anytime. My job is to make sure that you guys have the resources that you need as surgeons practicing in America to deliver the highest quality care to our patients in the most effective environment that we can help you achieve. So thank you so much. Yes.
Paul Perkowski, vascular surgery. I've been on boards of State Medical Society. We've served on another services committee for a long time. What we notice is that most doctors, they join the AMA and then they join their specialty societies, whether it's plastic fashion or whatever.
Mm-hmm.
So it's hard to get them to join anything more than that, especially when they realize that they get a lot of benefit without paying dues. Because you're advocating for all surgeons, whether or not they're a member. So how do you get how do you get into the mind of that particular person, realize that they're going to get some sort of benefit without being abused?
So the number of people that belong to the AMA are about 20%. It's a really small number, right? So our goal, my goal, is to recognize two things. That we can't be, I'm never going to replace SVS as your educational resource. And I want you to be a member of SVS because I think it's really important. But I also think that we benefit as the college and as surgeons in general with the House of Surgery concept delivering more people to our membership to say we're representing now 150,000 surgeons, not 90,000 surgeons. We're representing a broad swath of all of those specialties, not just a few people in each one. I mean, I think there's like 600 OB-GYNs that are members of the college. It's a small number. That doesn't really resonate, but there's 30,000 OB-GYNs that are out there. And my job is to share with them that there is benefit. I think I've got an easier job with you, because, correct me if I'm wrong, you did a 5+2, right? So you saw what general surgery, the value of the college as a general surgeon, and then staying in after that is a little bit easier, and the statistics would argue it. But your residents, do you guys have a vascular residency? No. But many of the vascular residencies are now 5-year integrated programs, or 5+1s. So those are a harder sell because they didn't spend time as a general surgeon. What gets people to join an organization? The number one thing that gets people to join is somebody like you, or me, or Dr. Z, saying, this is important, you should do this. So it's really hard to get a group that doesn't have a whole lot of people to make that argument. But in your situation, I think it's different. So you have the ability to influence other vascular surgeons and articulate what you get out of the college. And we're trying to do that on a big scale, but where the rubber meets the road is at the personal level.
And the value of FACS, as you look at the jobs, it's huge. There's no doubt about it. Would you come out of your mind?
Well, we've got, one of our biggest groups that's not general surgery is plastics, right? So why is a plastic surgeon who doesn't bill Medicare, I mean, big picture, right? You know, so they do good work, but there's a lot of plastic surgeons that, you know, don't bill Medicare, they operate out of their office, and, you know, they have a great life. Why do they do it? Because it's a sign of quality, and the guy next door to him has FACS behind his name or her name, and they're in competition. It's a market driver, and I showed you that from the Forbes article, that participating in these organizations will help your business. So, you know, it's a big thing in private practice in many places, especially in competitive markets. So everybody's looking for a little bit of an edge, and, you know, the more letters you can tack on behind your name, that is perceived as a positive thing by patients. So that's a real aspect of it.
Appreciate Reed Grimes, record surgeon. You didn't try to cover everything the college does. I just want to mention one for the residents that are finishing, and that's the surgery-specific registry or case registry. The residents hate the case logs.
Right.
But when they get out into practice, they need those case logs. They need them for recertification. And it gives you a chance. Our memories aren't great. You can go back and look and see what you've done and where you've done well, where you've done poorly.
Absolutely. The SSR is phenomenal. It is a qualified clinical data registry with the CMS. So if you're participating in something that requires that, it achieves that. We're, Lord willing, going to have a mobile app version of it back in the next year. That's a struggle, but it's a place that you can have all of your cases logged rather than having a book with a bunch of stickers in it, right? That's how most people do. And then you guys are used to it. So I mean, every case you do, you put into the system. Whenever I was in training, we had a checkbook, and you would have to fill it out by hand, and then you had this stack of duplicate checkbooks, and somebody else had to put it into a computer. your point's exactly right. There's plenty of things that the college has to offer, and our job is to help make sure that you're aware of those. And when you go out into practice, the ability to demonstrate quality and demonstrate what you do is going to be important. I just transitioned from Ohio State to Northwestern because I now work out of an office right next door to Northwestern in Chicago. And I had to show them how many robotic cases that I had done, had to show them exactly what they were. Same thing for laparoscopic, same thing for endoscopy. They're going to ask questions like that when you go out and apply for privileges at places, and the answers to those questions will impact your ability to be privileged in a hospital. So having access to that's really important.
All right, thank you. Dr. Michael Sutherland, MD, MSA, FACS, it should be MBA. Abramson Visiting Professor, the 51st.
Great. Thanks so much.
Go green.
I appreciate it.
All right, thanks. Come on, Sam.
Go ahead and now I have the presentation of the chairs to the graduating chief residents by Dr. Navdeep Samra.
Go in the order the way, going in the order the way they kept it. Yes.
I'll go ahead, sir. Dr. Tyler Albin, please come forward. I always find it very interesting whether they have a rocking chair or a sitting chair. Not sure of the significance, but maybe you can help. Come out up here. Come to the picture. Dr. Nicholas Gilbert. Dr. William Ishii. Dr. Stacy Lynch. Dr. Carolyn Song. right, I want to thank everyone. Dr. Sutherland, thank you so much. Great message you delivered. Your presence here will be felt for long, and you'll be up there with Dean Warren and all the greats, so appreciate it. We'll see you tonight. This concludes our ceremony today, so I would encourage you to come a little bit early, maybe. The park, and they're going to be doing the orthopedic graduation at the Shreveport Club, and we're next juxtaposed to that. So thanks again, everyone. Appreciate it, and I hope you had a good time today. Bye-bye.